Hi, Anjum.
So, ma'am, can you hear me?
Yes, I can.
My network always has issues.
Good evening, ma'am. Good
कुछ
evening,
नहीं कर
Anjana.
सकते यार. Hi, Nivedita. How are you?
Good, doing good.
Good, good. How is the
Yes,
weather? How is the weather? Because it's very
awful,
hot in here in Indore.
awful, awful.
Is it how many degree are you in?
Ma'am, have you forgotten the count only? 43, 44, plus the humidity is immense. Without AC, I mean, the moment you go out, even if you take a bath and come out and you're sweating profusely.
Oh my God.
And in the afternoons, you
Same.
just can't go out on the main road.
I know.
Good
Same.
evening,
Same.
everybody.
Hi, Rupali.
Good evening, everybody.
Hi, you. How are you? You are just like glowing, right?
भाग भाग के आ रही मैडम क्लिनिक खत्म करके आई केम होम बिकॉज आई फॉरगॉट माय लैपटॉप चार्जर
Is it? Oh.
तो मैंने घर पे आके अभी लॉग इन किया
I know, I know. We all are like running, morning till evening.
सीरियसली
Because हम लोग कैसे बोलते हैं घर आके 9 बजे की सांस ली है अब. और probably we think that कि breathing कोई टाइम नहीं है.
आई
अभी
थॉट
अच्छा
बच्चे बड़े होने के बाद आई विल गेट सम आराम वो तो बढ़ रहा है मेरा प्रॉब्लम अभी बच्चे बड़े होने के बाद
कुछ भी नहीं. अभी तो मीनोपॉज पढ़ोगे ना तुम तो तुम्हें लगेगा.
I'm already going through perimenopause. I feel like wanting to listen to this more than anyone else.
I know. I know it is like for women it's like a wheel. It runs and वो गाड़ी में डीजल खत्म भी नहीं होता actually.
Seriously, there is
I
nothing
don't know.
called
I
as
feel menopause
aram.
is a nice time. Menopause
How
is
was your
a wonderful
podcast,
period.
madam?
पॉडकास्ट बहुत अच्छा हुआ. इट वाज सुपर. अभी
हाँ,
देखना आज वो शायद वो आज तुमने देखा था क्या डीप डाइव वन वाला जिसमें लॉस्ट इंस्ट्रूमेंट एंड देन सेकंड वन इज कमिंग विद द मायोमेक्टमी डन विदाउट आई मीन हिस्टेक्टमी डन विदाउट कंसेंट. सो दैट्स
wow.
that I think that must be there today. Let me check if they are posted. So
Oh, great, nice. Hello,
yeah,
good evening, Dr. Nivedita Datta ma'am also.
yeah, she's here.
Yes,
I'm here.
yes. Hi, Dr. Anjum,
Hello, ma'am. Hi, Rupali. Hi.
my twin sister.
We have under so much of stress till this is done.
Bhagyashree is also joined, I think.
Yeah. I,
Madhu madam join हो गए हैं.
Yes, ma'am.
hi, Dr. Bhag.
Hello, ma'am.
Yeah, hi Bhagyashree, how are you?
I'm good, ma'am.
How good?
Good evening.
Good evening.
Um,
Hi, good evening, Dr. Anju.
Sound once.
हाँ हेलो हाँ वीडियो है ना एम आई ऑडिबल डॉक्टर अंजुम एम आई ऑडिबल
Hi, Dr. Madhuri.
ma'am, you're audible.
हाँ एम आई ऑडिबल
Yeah, you should be.
Am I audible, Dr. Anju?
Yes, ma'am, you are.
ओके थैंक यू
Hi.
Mother, you should ask them if you are audible.
हाँ दैट्स व्हाट
Hi,
आई
Dr.
वांटेड टू
Madhuri.
हाँ डॉक्टर अर्चना एम आई ऑडिबल क्लियरली देयर वाज सम प्रॉब्लम
No, not at all. You are
Okay.
very well. We can hear you.
Yeah, thank you very much. So I have shared the presentation and Dr. Shobha madam has joined.
Not yet, I think.
Okay, doesn't matter. So today we are going to navigate how to manage menopause. and most of us, we do know the basics of it. But Dr. Shobha has made one very good prescription writing module that we should be finally at the end of it should be doing it. So it has been taken from that. It has been taken from that, and initially she will introduce what menopause is about and what are the new changes which has come up in 2024 guidelines. And for that, if she joins, she will start. Otherwise, maybe I joined late. We can, Doctor, I can see Dr. Shubha Sharma and everybody. We can just take their blessings and start.
Yeah, just a minute, Dr. Madhuri. We will be waiting for a few minutes for our chief guest
Huh.
to join in. So we
Yes,
just
yes,
have a little
yes,
formalities to do.
yes,
So
yes.
we will just introduce. Is Purnima joining, Rupali? Dr. Purnima Satoskar, our waste zone chair. You have to unmute yourself, Rupali.
या मैडम मोस्टली नहीं, मैं वापस एक बार मैडम को पूछ लेती हूँ.
नहीं तो डॉक्टर शर्मा को पूछ लीजिए, लाइक ज्योति मैडम ज्वाइन कर रहे हैं क्या, डॉक्टर ज्योति?
Join करती है शायद. Sudha ma'am, I can see her.
Yeah, so
I
Dr.
couldn't
Sudha,
see
I
Sudha
think,
madam.
Yeah.
मैं बात करके देख लेती हूँ.
yes, Jyoti, please.
Sudha ma'am join हुई हैं.
Yes, yes.
Ma'am unmute करें आप.
और जिग्नेश भाई ज्वाइन किए कि नहीं, जिग्नेश
Yes,
भाई?
yes, I am here.
Yeah, thank you, जिग्नेश भाई. So કેમ છો જિગ્નેશ ભાઈ, બધું સારું છે?
બધું સારું છે. તમે કેમ છો? બધું સરસ
મજામાં
સરસ કરી રહ્યા છો.
મજામાં.
Sorry for Gujarati words for all the panelists.
A few things, like when you travel so much, you learn few things, no?
Yes,
Few first words of every language. So how was your Japan trip?
excellent.
I think everybody is going to Japan. My son is
Now,
in
yes,
Japan for
yes,
15 days and he is going
because
to.
Europe and Northeast, few people only gone. So most of the people's preference was Japan, and we have huge crowd equal to Vietnam in Japan.
Hmm.
There's a lot of
जितने भी
unrest out there, no? That's why also problem. A lot
जितने
of
वियतनाम में थे इतने जापान में थे.
unrest.
नाही, कारण काय आहे, ते युरोप एकदम खूप महाग झाला बिकॉज ऑफ दॅट द वार थिंग. You have to take the
Yes,
flights,
because
too
of war.
long flights. So people don't want to spend too much on the travel because rather they'll spend on staying in good property and enjoying. So like so many of my known are in Japan. Even I told my son and daughter-in-law for 15 days just enjoying the Japan. Quetta and everywhere they are on one island. It's a very interesting museum island,
Yes.
art island. So
Yeah.
they are staying inside the museum.
Oh.
Yes, and they are both of them are art lovers, so they're just staying there and a beautiful pictures. So I think now 7:33. We are just waiting for Dr.
अर्चना
Sudha.
आपको एक बार डिस्टर्ब करूंगी मैं. सुधा मैडम ऑलरेडी हैं ऑन बोर्ड एंड शी कैन सी यू. आप एक बार सुधा मैम प्लीज आप थोड़ा सा कुछ बोलिए तो आप सामने में आ पाएंगे.
Hmm.
Madam mute है sir.
Dr.
Sudha madam.
Sudhesi is already there.
Ah, Sudha Sharma ma'am is already there. Actually, she's unmute
Yeah.
also.
She was asking that is she audible?
But she's unmute also. I mean, audible.
Madam is on mute, I think.
नहीं म्यूट पे नहीं दिख रहा है उनका. It's not showing mute.
So Jyoti is probably trying to check, madam. So Sudeep ji ko we can then once Dr. Sudha joins her, we can locate her. We can start.
Dr. Rupali, have we sent the link to Dr. Taruchaya madam because she has not received link?
Yes, I have sent her and she said she'll be joining.
I have
Received the link also.
I've told the check-in spots spam box.
Yeah. No, I sent her on a WhatsApp also. Fresh Abhi Wapis. So I think she will join now.
She said she'll be joining after 8:30, you know.
Yeah. But अभी उन्होंने call किया था, then I had sent her the link on her WhatsApp.
Mm-hmm.
Hello.
Hi, Dr. Sudha.
Yeah, I have joined from the phone. I don't know what has happened to my laptop. So I was there since long, but I think my voice was not audible. So I have joined now with the phone.
Thank
So
you so much. Thank you so much.
so
So I think now
uh,
quorum is complete to begin the meeting. So Dr. Rupali and Anjum, can we ask Sudeep ji to give us the countdown and we can begin?
Yes, madam. We'll just start it, and with the lamp lighting, we'll start the video.
Shobha Gudi madam has joined?
Not yet, not yet, ma'am.
Just give her a call, no? To Shobha. Do you want me to give her a call, Anjum? Do you have her number?
I think I have a number, ma'am.
Can we start with this lamp lighting?
I think meanwhile you can start with the lamp lighting, Sudeep ji. So
Yeah.
by the time our guest of honor and chief guest will be addressing, Dr. Shobha will join.
Yeah. This will go live in 3 seconds. 3, 2, 1. We are live now.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
Thank you, Sudeep sir. I welcome all the guests, esteemed faculty, all the delegates who have joined us from across the country on this webinar conducted by the AICC RCOG West Zone in collaboration with the Indian Menopause Society. Menopause, we know, is a natural transition, but still 70 to 80% of the women develop some kind of disturbing symptoms during this period. And out of this, 20 to 30% have severe symptoms. So menopause is not just about hot flushes, but the symptoms can be emotional, physical, psychological, affecting the daily activities, affecting the interpersonal relationships, as well as sometimes affecting the quality of life. That is why the focus today in the focus series is on managing menopause. I request Dr. Rupali Dharwadkar to introduce our program director, Archana Basel ma'am, who is the director of Focus Series. Thank you.
Good evening to everyone. I am very happy that we are getting to introduce Madam today. Everyone knows she's a dynamic personality and she is now the right candidate, I think, for going for the Foxy presidential candidate election also. Madam, our very good wishes are there with you. We all are with you. And we hope to see you as a president soon. Madam has been the Vice President Foxy in 2020. She's been the Chairperson MP ISAR 2527. She's a fellow representative of the AICC RCOG West Zone. And she's the Joint Secretary of ISPAT 2527. She's also the Organizing Secretary of AICOG 2021 Indore. Madam has held quite a lot of positions in the past, being the chairperson of the Foxy Imaging Science Committee, organizing secretary of ISAR, managing committee member of ISAR, imaging science member, AOFG, and imaging science committee chair of the SAFOC 2020-2023. Apart from this, she is an amazing person and an excellent doctor par excellence. We look forward to hear her talks because they're always innovative and her slides are very, very informative. And the video presentations which we have seen in the past webinars, they're really something which we have taken a lot of take-home messages from. Over to you, ma'am. We welcome you. And I invite you to invite the guest of honor and the chief guest.
A very good evening. Namaskar. First of all, let me thank the RCOG chair, AICC RCOG West Zone chair, Dr. Purnima Satoskar, for giving us this opportunity to do focus series. I think it is our 12th in a row, our focus program. And I'm being flanked by two very strong and two person, Dr. Rupali Dharwadkar, Dr. Anjum Syed, who has been really instrumental in connecting with you all and doing the collaboration. This time, what they said that, Madam, why can't we just do, because menopause is something which we really need to talk about and which we want to hear from the specialists who are really practicing the menopause. And this, I attended recently the IMS National Conference in Bhopal, where I happened to meet Dr. Sudha Sharma, Dr. Jignesh, Dr. Jaiswal, and all the members who are here today. So I just called up and I said, Dr. Sudha, Dr. Jaiswal, can we just have collaboration and do this program with the IMS? I was so happy that in one word, Dr. Sudha Sharma said, why not? We really are now, it is a very burning problem. It is a hot topic because the heat is there and the menopause is associated with lot of hot flushes. It's not only hot flushes, the managing the menopause, the life during menopause, because there is longevity of Indian women have increased, and it is important that we address this issue. And there are multiple problems. It's not only just the health related, there are the mental issues, and all the problems are there. So today we have as our guest of honor Dr. Jignesh Shah. And Jignesh Bhai I have known for many years, and he is the immediate past chair president of Menopause Society. So I would like to invite Dr. Jignesh Shah for giving his words of wisdom and what he thinks about this webinar when we talk about managing the menopause. Can I have the CV of Dr. Jignesh Shah? I think Dr. Jignesh Shah is the senior OBGYN practitioner in Ahmedabad for over 40 years, and he is past president of Indian Menopause Society. He is life member of Ahmedabad Obs and Gynae Society, IAG, ISAR, number of state and national level conferences he has organized. And His center is recognized for Foxy for basic and advanced ultrasound training. And what I know Jignesh Bhai as a very humble person and go-to person, if you just tell Jignesh Bhai you have to come, he will be there for you. So over to you, Jignesh Bhai, for your words of wisdom and advice to us. I think, have we lost Dr. Jignesh Shah from the...
Now you can hear, I think.
Yes, Jignesh Bhai.
So thank you, Dr. Archana ji, for today's invite, and thank you, conveners of this webinar, Dr. Archana Basir, Dr. Rupali, and Dr. Anjum, and the whole organizing team for today's invite. Congratulations to AICC, RCOG West Zone Focus Series, Rediscovering Yourself and Managing Menopause, and especially jointly with our own Indian Menopause Society. So I congratulate our President of Indian Menopause Society, Dr. Sudha, and Secretary Dr. Jyoti Jayaswal also. And thanks to the Program Director, Dr. Archana, and IRC Chair, Dr. Purnima Satoskar. I think she is not present at present. So management of menopause is very important as the lifespan increases. Now, today, the average age of Indian woman is 72 years plus, but we don't want to offer them only longevity. It is the quality of life that matters, and for that, careful management of menopause is very important. So, today's topic in this webinar are very important as well as interesting. The first panel on MHT in specific conditions is important to discuss in present era, because now we are getting patients uh, treated for CA cervix, CA breast, CA endometrium, as well as patients who have got transplant, diabetes, hypertension, obesity, as well as patients who had gone under bariatric surgery. And they are coming to us with the symptoms of menopause. So, as a gynecologist, we have to understand their need and what type of MHT, whether we can give it or not, and if we want to give it, how to give it, that is important. Second talk is in very important. Since last 6 years, we are working on it, and that is how to establish menopause clinic. At Indian Menopause Society, it is our motto that all the gynecologists across the India should have a dedicated menopause clinic either once a week or twice a week, with a dedicated time of 1 hour or 2 hour, and that will change the whole scenario for the menopausal woman. Many of the gynecologists think that it is very difficult to establish menopause clinic, but believe me, you don't need any extra resources if you are having your gynecological OPD, and if you follow protocols. It is not difficult to manage the patients of menopause. So I think anyone and everyone can and should have a menopause clinic in their OPD. I think all the viewers will have good take home and will be benefited by today's webinar, and my sincere best wishes to today's webinar. And thank you again, Archana ji, for today's invite. Thank you.
Thank you. Thank you, Dr. Jignesh Shah, sir, for giving a really insight into that why we really need to set up the menopause clinics and give a special time to women, because they need a special time, because they need some kind of shoulder or somebody to listen to them. So, because the children are gone and they are going through menopause, it is important that we have separate clinics. So, thank you very much. Please stay with us. Now, it is my pleasant duty to introduce and invite the current president of Indian Menopause Society. She is our chief guest, Dr. Sudha Sharma. It comes from the Jammu, the place where we think that it might not be as hot as everywhere else in the country. So, and then she is president IMS for 26, 27, and she is a wonderful person. She has held many positions, and she has been president of Jammu Obs and Gynae Society 2018 to 20. She has 90 publications, and she has edited 11 books, and she has written book chapters 10. The most important thing, what I liked about Dr. Sudha Sharma, is when I said that you have a very enthusiastic and very, very proactive secretary in Jyoti Jaiswal. She said that, yes, I'm really very blessed and lucky to have Jyoti, but at the end of the day, it's like a teamwork. And I consider IMS as my family. And when you work in any organization or any association, considering that it is a family, and then we have to reach our message to masses, we have to collaborate. And I'm really happy to do this webinar with AICC RCOG Waste Zone. And over to you, Dr. Sudha Sharma, for your advice and your kind words on this webinar. And how do you see the future of menopause clinics and the managing the menopause?
Thank you so much, Dr. Archana, for that introduction and for those kind words. I'm honored. So, a very good evening, everyone. My heartiest congratulations, dear Dr. Archana, and your team for organizing this AICC RCOG West Zone Focus Series and collaborating with us as Indian Menopause Society. And thanks for inviting me to this prestigious platform, where we have, Chair IRC, Dr. Purnima, where you are there as fellow representative with Dr. Anju. You have member representatives, Dr. Rupali, Dr. Latikash, and Dr. Shriya, and our own Dr. Jignesh. We've just heard him, the moderators, the panelists, and Dr. Charu and chairperson, everyone who is present on this platform. It is such a pleasure to share this platform with you all. And you have chosen these topics, very appropriate topics. You know why menopause health care has gained popularity over the years? Because as we females are living in this phase for quite a long time, I give this example that Asha ji has passed away at the age of 93. So can you believe she must have spent close to half of her life in this phase? And once you are spending a huge span in this phase, you are going to experience challenges in this phase. And I have seen a visible shift. Menopause is entering public health space. Awareness is improving, though still not adequate. The shift is towards a general health issue, and there is growing global recognition that menopause should be approached as a multidisciplinary health phase. you know to tell everyone over here that I joined this society way back in 1999, 27 years ago, and have been working in menopausal health since long. I have seen a striking shift, and I would put it like this: from silence to open conversation, from inevitability to treatable conditions, shifting paradigm in menopausal hormonal therapy, expanding focus beyond hot flashes. I have seen the social and the digital influence and the cultural shift. And now it is from silence to tolerance to awareness and active management. And when we are talking of these menopausal health clinics, can you believe Maharashtra has launched 500 plus government menopause clinics in 2026? And it does not take much resource and this thing, as Dr. Jignesh has told us, that it just requires a very simple setup which you already have. So I really wish a successful webinar my all the best wishes, and thank you once again for inviting me. And if I really wish all the best to you, Dr. Archana. You are a an appropriate candidate for the amount of work you have done in the Foxy, and as a women health. I sincerely wish you all the very best.
Thank you. Thank you, Dr. Sudha, for your kind words and your insight into that women are spending more years of their life in menopause than in their reproductive health, as you have given example of Dr. Of Asha Bhosle ji. So I think this is a momentum is the need of the hour. So very well said. And I think now we take the scientific program forward, and for that, for the panel, we have Dr. Madhuri Joshi, Dr. Shobha and Gudi. I think I'm really thankful to all of them, and especially Dr. Madhuri Joshi. When I spoke to Rupali, she said that Dr. Joshi has given her, the faculty from all around the country, from the north, south, east, west. You name a place, and I have, madam, in my faculty list, all the faculty from all over the country. So I welcome all the faculty who have joined in as a panelist, who have joined in as a chairperson and as a speaker. Over to you, Dr. Rupali and Dr. Anjum, to introduce our moderators, and then moderators to introduce our panelists.
Dr.
Dr. Madhuri ma'am.
Beginning this session, she is the master of ceremony and gynecologist who is the member of AICC RCOG.
Hello, ma'am.
Yeah, Anjum, your voice is, I think, the network issue again. We warm welcome to Dr. Madhuri Joshi, madam, and Dr. Shobha Gudi, ma'am. We are really honored that you are the moderators, and I'm happy I'm not the panelist because I'm sure the panel discussion is going to be a really an amazing panel discussion. Dr. Madhuri Joshi is very much from Mumbai, and she's from Nanavati Max Super Speciality Hospital. She's a peer reviewer of Jogi and Journal of SAFOG, executive member of the Midlife Crisis Committee, FOXY. Madam has on the FOXY Ad Board expert member on formulating the guidelines on iron deficiency anemia in perimenopause. Most important, Madam is a CIMP examination trainer and coordinator as well. So even when in my practice, I have any queries on menopause related thing, we work in the same Mumbai city. So I'm always the one to give her a call, and I always get the right answers. Welcome, ma'am. A warm
Thank you
welcome.
very much. Thank you.
I have Dr. Shobha Gudi, ma'am. Can I have Madam CV? Madam doesn't need an introduction. We are really honored that Madam has come today and accepted to be the moderator for the same. She's a professor, HOD at the St. Philomena's Hospital, Bangalore. She is a VP of the Elect South Zone, FOXY. Ma'am has, to her credit, she's been the editor of the Obstetric Hemorrhage Yearbook ICOG 2025. And
Thank you, Rupali. Thanks a lot, Rupali.
Publications as well. A warm welcome to you, ma'am. We are so looking forward to a very interesting panel discussion today.
Welcome, Shobha.
Hi, thank you so much, Archana. Thanks a lot.
So I think you people now start the scientific session, introduce your panelist, and let's get going.
Yeah, we call upon Dr. Bhagyashree to introduce
Yes,
our
ma'am.
panelists. Yes, Bhagyashree.
Warm welcome to all the faculties. Thank you for joining in. I would like to introduce Dr. Vipasa Sen, ma'am. Ma'am is a consultant. She has been the Vice President of Indian Menopause Society. Ma'am is also currently the Secretary of Public Health Committee of Bengal Obstetrics and Gynecological Society, and she's a member of various societies. Ma'am has been faculty at national international meeting at Canada, Czech Republic, Bangladesh, Pakistan, Australia, and Malaysia. Importantly, ma'am has won awards, Times of India Award for Outstanding Contribution to Healthcare on Women's Day and Nanni Peri Foundation Award. Thank you, ma'am, for your presence.
Thank you.
Next, I would like to invite Dr. Geeta Sudhir, ma'am. Ma'am is a senior consultant obstetrician at Bangalore, and ma'am is trained in aesthetic regenerative gynecology as well as minimum access surgeries. And area of interest are high risk pregnancies and menopause. Thank you, ma'am, for joining us today. Next, I would like to invite Dr. Mini Baby ma'am. Ma'am is the head of department of Adesh Institute of Medical Science and Research in Bhatinda, and she is the founder of Bhatinda Menopause Society, and she has been examiner in OBJ of various institutes. Ma'am also has various publication in national and international journals, and she's also a reviewer to various journals. Thank you for joining in, ma'am. And next, I would like to introduce Dr. Monica Agarwal, ma'am. Ma'am is a practicing consultant in her care clinic in Surya Criticare Hospital. Ma'am has also won 2 awards for a case presentation of a very rare case of vulval fibroid. Thank you for joining in today, ma'am. Next, I would like to introduce Preeti Gupta, ma'am. Then, ma'am was she's the secretary of Bollywood Menopause Society, and she's also been the past secretary and vice president of the Waller OBGY Society. Then ma'am has also won many prestigious awards, which is the MS Signature Award for Social Work and Nai Dunya Naika Award in 2025. Ma'am also does a lot of social work. She's associated with multiple NGOs, Astitva, Rotary Club, and organizes various camps like Dhira Camp. And she's also been teaching self-defense in government hospitals. Thank you so much for joining in, ma'am, today. And next, I would like to introduce Sudha Goel, ma'am. Ma'am has done fellowship in infertility and endoscopy. She is a gynec oncosurgery and robotic gynecologist. Currently, ma'am is director of Kamla Hospital, and ma'am has also been the president of Rotary Foundation Club of Jodhpur 24-25, and she's also the secretary IMS of Jodhpur Society. Thank you so much for joining in today, ma'am. And then next, I would like to invite Vandana Gupta ma'am for joining. So ma'am is the coordinator of Delhi Gynec Forum, and she is the chairperson of GDM and stillbirth prevention. Ma'am is a gold medalist during her MS exam. Currently, she is a senior consultant at Max Hospital Pratapganj and Apex City Hospital. Ma'am has won many awards, including the GP Rawat Memorial Gold Medal, then Wazir Singh Choki Silver Medal, Doctors Day Appreciation, Abdul Kalam Award, and multiple awards in the past. Thank you so much for joining in today, ma'am. Then next, I would like to involve Nivedita Datta, ma'am. Ma'am is consultant at Bokaro. She has also been the past president of Bokaro Obstetric and Gynecological Society, and ma'am is the member of Maternal Perinatal Health Committee. She's also palliative care specialist and has been faculty at various national and international conferences. Ma'am also has many articles in Foxy accredited books and even GCR. Thank you for joining in today, ma'am. And then I introduce Dr. Pranay Fukan, sir. He is the professor and HOD of Assam Medical College. Sir has been an undergraduate and postgraduate teacher for 34 years. He is also ICOG visiting professor, and he is the recipient of the Young Gynecologist Award. Sir is the president of the Brugger Obstetric Gynecological Society and also president ISO PAR Dibrugarh. Sir has more than 50 original publications. He is trained in Boston, USA, and he is also a chief editor of the Handbook of Infertility for Practitioners, which is published in 2022. Thank you for all the faculties for joining in today.
Thank you very much, Doctor. Now I will request Dr. Shobha Gudi, madam, and she was really at the last moment very kind enough to really think what we should be really presenting. She like if her menopause prescription writing goes houseful, and this from the same this she has taken all the good PPT she has shared with us, and in that she is going to introduce the topic, and then we will start the panel discussion. Over to Dr. Shobha Gudi, madam.
Yeah, thank you so much, Madhuri, and it is very kind of you to involve me in this way, and I am delighted actually to address all of you on this subject, which is very close to my heart. I think let me share not this, I have made my own. So let me share. Yeah, I will share. It's better that I share. Yeah. Actually, because I was also able to, add all the panelists in the last moment. So can you see? Can you see this? Is my slide seen?
Yes,
Yes, ma'am.
It is seen, and I'm audible also, right? So
Yes.
welcome to Bipasha in particular, because Bipasha has been the secretary when I was chairperson of the endocrine committee, and in the next year she was, I think, she's the vice president at present. So thank you, Bipasha, for being here. Thank you, Sudha, for
Thank you,
such.
Shubha.
Yeah, and Sudha also, and Jignesh sir also for coming here and blessing this webinar. I'm sure Jyoti also must have joined at some point. I must thank Dr. Archana Baser for thinking of this webinar and her team also. And with that, let us go forward. Let me just say that let us discuss some clinical aspects of how to manage midlife women. Very, very clinical, just as they walk into the clinic, and that will make the session very interesting. And we shall not touch upon theoretical aspects so that the interest of the audience and the panelists can be on edge to answer. So actually, Madhuri said that initially 4 5 slides I should do in introduction, but I will be asking questions in the same tenor, so you
Yeah.
can feel free to answer also. So menopause hormone therapy and menopause management, it requires evidence-based guidelines, yes, but you have to craft that evidence-based information that you have in such a way that it suits the woman in front of you. It has to be individualized, and then you have to create a team who can look after her. That means it is multidisciplinary from the very outset. So we are doing only part of the care, and we are taking help from many people around us. And that is the right way to go about it. So as far as MHT is concerned, in general, we speak about the right patient, the right time, right choice, right dose, right route, etc. But then as you go along, you will develop some reflexes, and which will make you write the correct prescription for the woman without thinking of so many variables. Immediately the answers will start coming to you when you start getting familiar with this. We still adhere to the straw plus 10 staging reproductive aging climacteric, and according to that, we are all aware that the significant effects of menopause are the symptoms are only the tip of the iceberg. The menopause transition and beyond takes a toll on almost every organ in the body. It is not just aging and geriatrics which sets in, but the hormonal transition makes women vulnerable to changes in the epithelium, in the endothelium, in the bones, in the heart, and in the brain, etc. But yes, the hallmark is when the woman starts feeling the vasomotor symptoms, and maybe some mood and sleep disorders. Urogenital atrophy and dyspareunia sets in a little later, but that is what is critical. We should kind of, start looking at them, treating them, offering them solutions before the atrophic changes set in, before the osteoporosis sets in, and before too much of atherosclerosis comes her way. Any which way, age-related and genes-related atherosclerosis is going to hit her at some point of time, but we can minimize the one which results from the drastic transition of menopause. So also goes for the cerebrovascular disease. So the menstrual disorders which crop in between, will tell you about the waning hormonal milieu of the woman. Now, from the panelists, I just want to know what do you see in your women? Which symptoms do you see? So any two panelists can answer, and then I can go on to the next slide. Madhuri, you want to add anything in this slide?
No, madam, very comprehensive. Please let us
Mm.
see what our panelist has to add.
Yeah, panelist, please.
Most
Anybody?
common, yeah, ma'am.
Most common are
Yeah,
vasomotor
can I see?
symptoms.
Yeah, one by one. Yes, please. You can just
Yeah,
identify your name and start talking. Yeah.
yeah, I'm Dr. Monica.
Yeah.
Yeah, so I feel the most commonest symptom they come with is the vasomotor, that is hot
Yeah.
flushes, night
Mm,
sweats. These are the
mm,
most commonest symptom. They have
mm.
insomnia, sleep disorder, as well
So
as
in your
sexual.
experience, you see that first, right?
Yeah,
Vasomotor.
sexual health, dryness, vaginal dryness, and they have burning sensation. They also
Yeah.
come with the complaint of recurrent urinary tract infections.
Mm,
So I
mm,
think these are the most commonest thing that they come
mm.
up with.
Correct. Anybody
Yeah.
else? One more
Good
person?
evening, ma'am. I'm Dr. Minnie.
Yeah, Mini. Mm,
Well, what I personally believe is the vasomotor symptoms are the first to occur, and it is the
mm,
most common. But then
Correct.
urogenital symptoms are also not very uncommon. I
Hmm.
mean, people do come with the urogenital problems as well,
Correct.
especially the vaginal dryness. And I mean, they are not very open to talk about the sexual
Hmm.
health, but
Hmm.
yes, they do talk about the vaginal dryness and irritation,
Correct.
the
So
urgency, the
these are
frequency, and all those
signals
things.
that the woman requires therapy. I hope you all agree. These are signals that the woman requires
Agreed.
therapy. Yeah, agree. Because we can't beat around the bush and say, okay, you use lubricant, okay, you use a cold water bath, or you wear cotton and you sit under the fan. All those we should not say. She can do that, but in addition, she requires therapy. And then, what according to your mind? Can I request anybody else, Dr. Sain or Dr. Fukan or Dr. Gupta, anybody can take this page? What,
Yes.
according to you, rings a bell in your mind regarding age? How do you look at age in relation to MHT?
Yeah, many
I'm
women actually they start their having these problems before menopause. Quite well before menopause from 45 onwards. Many people many person I mean women they come with this problem, and especially they start along with their menstrual irregularities. They might be complaining of some vasomotor symptoms or so in those group of patients very carefully we have to select them, and definitely if they need especially for the vasomotor symptoms or urogenital problems or psychosexual I mean some sexual problems, we have to go for HRT. And of course when the patient is around she had attained menopause, but they might come after 2 or 3 years after menopause, and definitely we have to find out them, and then we have to start it because if a patient I mean lady is complaining of menopausal problems, we are not treating with HRT.
Yeah,
It should be
correct.
it should be considered as not a I mean
Yeah.
proper.
About age, when would you like to
Yes.
start?
Hello,
Would you
ma'am.
like to? Hello.
Yeah.
Hello.
Hello, ma'am.
Yeah,
I'm Dr. Preeti Gupta.
yeah, Preeti.
According to my opinion, age is a very important factor to decide the start of the menopausal hormone
Yes,
therapy.
yes, yes, yes,
If the
yes.
patient age is less than 50 years, that is
Mm,
not a natural age of the menopause. She has to be start HRT if all the factors are normal and she is low risk patient. If the age is less than 60 years or within the 10 years of the menopause, it is also a very important factor to start the HRT for
yeah,
the
but
well-being
more
of
than
the
60, we are cautious,
if
right? More,
yeah, if
Yeah.
she is more than 60, we just do the symptomatic treatment.
correct, correct.
Can I add?
Yeah, please
Uh,
add. Yes, Dr.
yes.
Singh, please add. Yeah.
Actually, there are two things to add, I think. Not only the age of the patient, but years since menopause should be taken into account.
Exactly. Yeah,
Menopause, that is very important.
correct. Mm,
So that because if it is beyond 10 years of menopause, suppose someone has had menopause at 46 years and she comes to me at 57 years,
mm,
then I cannot on the first
Start.
day I cannot offer a MHT on the first day. And
okay,
another thing is
okay.
that we have to
Mm,
look for the comorbidities and other things in her.
okay.
Even if she is well within her age,
Mm,
still we have to look for the comorbidity so that we can
yes.
individualize, we can make choice of what.
Excellent point, Dr. Sen. Excellent point. So we are looking at the five W's here, right? Dr. Sen, you agree with
Yes,
me? Who it
yes,
is for?
Australia.
What are the types, doses? Yeah, this is from the white paper directly.
Yes,
It
Australia.
just triggers all the right questions in your mind: when it should be started, when it should be stopped, and why is it important, and where can MHT be accessed. So according to me, if you are in sync with the fourth question, why is MHT important? Everything else falls into place. It requires very little conviction then to know that it is required, right? So, why is it important? Is it has huge benefit in terms of prevention, etc. So, this is in general a flow chart of women who are assessed at the time of presenting to the clinic, and we will learn more about this in the next session when the menopause clinic setup is being discussed. But here we do assess women for their eligibility. That means that how much symptoms they have, and whether they are cases of POI, etc., or early menopause who require higher care. What is their bone health looking like? As Bipasha correctly pointed out, are they within 10 years since menopause? Very, very solid point she gave us. And, are they open to hormone therapy, or do they prefer
non-hormonal? Do they prefer which route of the hormone? And then we rule out contraindications. That's what also Dr. Sain brought out extremely well. Please rule out contraindications. Please rule out, cardiovascular disease or high risk for that or thromboembolism, autoimmune disorders, uncontrolled diabetes, hormone dependent tumors, active liver disease, of course, suspected pregnancy or undiagnosed abnormal vaginal bleeding, etc. And be very cautious in women who are smokers or obese, migraine, dyslipidemias, active gallbladder disease, etc. And go for transdermal route. So these things we will go on discussing throughout the this thing. So don't get worried that you are not having a no opportunity to present this. Definitely, all of you will be able to express your thoughts on these matters. I thought that I will just put a overview here that if there are risks, it is not that you will not give any any treatment. You will go for other options. You will go for some other molecule, alternate molecule, etc. So these are very old recommendations, 2016, 2017 NAMS recommendations, all of them saying that you should give the lowest effective dose, etc. But since then, since we have come a little further on, and after the release of this white paper, which I am sure Dr. Bipasha Sain, Dr. Sudha Sharma were all there when this was
Yes.
discussed in, correct,
We
in
were there
fall.
in Australia in this International Menopause
Correct.
Society conference.
Correct, correct. And then that is the highlight of this, of that. What we have put up here is the highlight that it is very effective for vasomotor and genitourinary. I think all the panelists agree. And there are some keys to successful MHT, and one of them is personalization and shared decision making. So I think it's important to make the woman commit to the therapy and agree with you that what you are doing is for her benefit, and then assess along with you the benefit risk profile. And one word of advice which I might give as a little older practitioner is we should never think that the woman is not educated enough or not smart enough to understand. You utter the word hormones and they become very, very alert and they have their own opinion and they are very keen to know more, and also they have their own judgment about it. So please discuss with them, share the decision with them. And excellently pointed out already that um, healthy symptomatic women, these are very key words. They're healthy otherwise, but they are symptomatic because of menopause, and they are younger than 60 years, and they are within 10 years of menopause. So these four things, if it is falling in place, the risk of hormone therapy is, is far uh, you uh, less than what we would think. So women who are healthy, symptomatic, is very, very good to give hormones if they are less than 60 years. Transdermal, lower groups, and then POI and early menopause have higher risk of bone loss, heart disease. So they must be given actually vigorously hormone therapy till it is indicated. Um, this is again some more facts, and we shall cover this as and when it comes. The only thing which will not come up again in the panel is the compounded bioidentical hormone therapy. Unfortunately, it has its place in the market, and we must not go after it. Don't confuse this with phytoestrogens. This is something else. When you read the composition, you will know it is bioidentical hormone therapy, and please avoid it. So always look out for that. This is a slide which will come in the end, and I will discuss it in the end. Now, Madhuri, I think we will start asking them the questions. So please
Okay.
go ahead on the type of estrogen. Yeah.
Huh. Okay. So we know that uh, all of us, we know that estrogen in 90s, estrogen for everybody. And after in 2000s, nobody should take HRT. And now we know it depends. But the decision is complicated. And the molecule, not only estrogen, there are many types of molecule. So may I request and anyone who can just guide us what type of estrogens are available and which you will select and which you are more happy in what way?
Actually, Dr. Madhuri,
Yes, ma'am.
previously, initially, we used to use only conjugated equine estrogen because that was
Yes.
available. But later on, many things have come. Estradiol validate, even estradiol hemihydrate has come in dose of 1 or 2 milligram in combination with progesterone, of course. But now the 17 beta estradiol, in my opinion, it is the best because it has got minimal liver load, as you have already shown here. Estradiol validate has got extensive fast metabolism. But whereas 17 beta estradiol has minimal liver load and it has much less risk of venous thromboembolism. These 2 points, in my opinion, should be considered, and that's why I prefer now 17 beta estradiol best. And it can be given as spray also, transdermal also,
Yeah,
gel
correct.
also.
Mm.
Yes,
Yeah,
that
yeah,
is
please.
available.
Mm.
That's
Yeah,
why I prefer it.
yeah. Dr. Vandana, would you like to add anything here? Because आपका कोई experience है transdermal में या फिर
I
estradiol?
don't think she has joined. I don't think she has joined, Dr.
Okay,
Vandana.
fine. Okay, fine.
हाँ,
Anybody
so
else wants to opine,
Dr.
please?
Nivedita may take it if her network
हाँ,
connection
yeah,
is
yeah.
good.
Nivedita ji,
Yes.
Nivedita, hi. Mm.
Yeah, we've been using the vaginal estrogen jelly gels. I find them quite
Okay.
effective, especially in the vasomotor symptoms or even in the urogenitary,
Yeah,
especially in
correct.
the genitourinary symptoms. The vaginal estrogens are really very effective.
Correct.
Actually,
Okay.
transdermal
Yes.
estradiol is given on non-hairy part of inner side of forearm,
True,
inner side of
true.
thigh, like this.
That.
And the spray is also available.
Yeah.
Lenzeter
As a
spray is
daily
also.
dose, as an
Yes.
actuated delivery, daily dose, it's
Mhm.
1.65 microgram is
Yes, yes,
available. It's very
yes.
useful. Yes. So I just wanted to highlight here one factor that, we know that MHT alleviates the typical symptoms of menopause. It improves bone health. Early initiation, post-menopause, actually improves the survival and cardiac outcomes. So we must know that in addition to improving sleep problems, mood swings, etc., preventing bone loss, reducing fracture risk, when it is started less than 10 years after menopause, what we must remember is that it is very likely to reduce the risk of on-cause mortality in women and the coronary heart disease compared with placebo or no treatment. So I think this is very, very important that there is a 30% decrease in all-cause mortality and 48% decrease in CHD risks, according to some of the studies as late as 2019, etc. So it is important, and then the Cochrane database also 2015, the systematic review, that also. So there is good evidence to say that it can prolong life, but only when given at the correct time and given for the correct duration. So that is how it stands today. I just want any of the panelists to come on and tell us about the other lifestyle that you advise women.
Yes, ma'am.
Yes.
Lifestyle change is very, very important in the
True.
particular patients of the menopause because healthy diet is very, very important. If you are using the unhealthy diet, that is the risk factor for already for the CBD and all. And regular exercises are very, very important. Weight bearing exercises, brisk walking, and the positive attitude towards life and the meditation, all these are very, very important.
Mm,
If the
mm,
patient is a smoker, so she has to eat all about the stop smoking and even the alcohol, or otherwise minimize the alcohol, and also add antioxidant in her routine diet as well as oral antioxidants tablets we can add on. And the
mm,
calcium is very, very important because in these
mm.
patients there is a increase in the bone loss, so the calcium add
So
is
well
very, very
thought.
important.
Anyone wants to opine about
Yeah.
the exercise? No?
Yeah, actually,
Ma'am,
what
I
is
would
in
like.
this
I
with
One
this
minute.
like.
particular is
Okay.
Let Dr. Fukan say and
yeah,
then
yeah, this
Monica. Yeah,
particular is many women in India they are having some metabolic problems. So
yeah.
we have seen that the patients should be very careful about our diet habit, and
Mm,
especially if we don't counsel them properly regarding
mm,
her, obesity or when BMI is more than 25, and then probably she might have other problems. So along
correct.
with this medication, we should take care of our complete health, and
Mm,
then supplementation of calcium, vitamin
mm,
D, and
mm,
especially she should actually go for a regular exercise, And by
Mm.
doing that, probably many of the problems associated with menopausal, as well as during that time she might have
Mm.
some other psychological problems, what we call it emptiness
Mm.
syndrome and all. Everything should be taken care of by
Correct. Correct.
good
So it's
counselor.
a rather holistic approach.
Yes.
मोनिका जी आप कुछ
Could I
कहना
add
चाहेंगे?
another point? Could I add
Yeah,
another
I
point
would.
here? Could I add another point here?
Yeah, Nivedita.
Okay, definitely everybody has mentioned exercise, diet, healthy lifestyle. Also, adequate sleep is very important because this is the time
Yes,
when
yes.
we have mood disturbances
Absolutely.
and inadequate sleep. So,
Beautiful.
a proper
Very
sleep
good
and
point.
obviously going away
Very good.
from your mobiles for that time being.
I think it is there in the next slide. Yeah.
Can I
Yeah,
also add
Ma'am,
something?
in
yeah,
exercise, I
Mini.
would like to add one thing
Yeah,
that
Monica, and then
only.
Mini. Monica and Mini.
Yeah.
Yeah. Mm,
Yeah. So strength training exercises are also equally important because I
mm.
feel there is a muscle loss also along with the bone loss. And in the
Sarcopenia.
diet,
Mm,
yeah, in the
mm.
diet, she should have adequate proteins as per her weight. That is extremely important because I think that is lacking in most of the vegetarian diets. So I
Mm.
think these 2 points are extremely important when it comes to lifestyle. So basically, there are 5 pillars of lifestyle. One is diet, second is exercise, third is good sleep, fourth is stress relieving, like doing meditation or engaging in
Mm,
some hobbies, and last
mm.
is addiction. That is smoking should be stopped and minimum alcohol consumption.
Correct. Yeah.
To
Mini जी आप
summarize.
कुछ कह रहे थे? Mini, Mini. Mm,
Anji, ma'am, I just wanted to add one thing that these are all the prescriptions we are giving to the patient. We are
yeah.
telling everything to the patient. This you should do, this you should do,
Mm,
add this,
mm, mm,
avoid this, and
mm,
everything.
mm, mm,
I
mm,
think not only the patient, the partner, even the family also needs to be counseled together that this is a
mm,
natural
mm.
condition she's going through,
Yeah.
and
We have
we
a
need
point there.
to talk
Correct.
to her.
Mm.
We need to listen to her. 2 minute उसकी बात रोज की सुन लेंगे ना patient की, and patient will be happy like anything.
Yeah,
I mean,
thank you
this
so much.
should also
This is
added
Mini,
to.
since you have the mic now. This is about the pharmacotherapies other
Yeah.
than MHT that we use in
Yes.
menopause. So please opine on this, whether you
Yes.
have any experience, and then
Yes.
any other person can tell. Yes.
Yes, Dr. Shobha, in
Mm,
antidepressants, I have found, apart
mm.
from these written here, I have found SNRIs, venlafaxine, and especially
Yes,
desvenlafaxine.
yes, correct, correct.
Very
Very,
I have
good.
not included
very,
everything here. Yeah.
but
Correct.
desvenlafaxine and venlafaxine has been very helpful
Yes, yes, yes.
in
Correct,
combating
correct.
the hot flash and all
Yes,
this.
yes, yes. So this is a further evaluation treatment plan, duration, how to stop. So you can always write down the plan for the woman. See that you have not left any of the boxes unchecked. And we hope to, revise all this when we come to the menopause clinic segment. Now, I put this a little general kind of a thing. It's actually available, this chart everywhere, but it gives you a very correct sense of the how we prescribe MHT in the cycle or in the woman's life in a monthly basis, because women are adjusted to cycles throughout their life. So MHT also kind of conforms to that sometimes. Sometimes it is very low dose and it is continuous combined, as you can see in the last one. No break, no bleeding, continuous combined. Now this goes for post-menopausal women with the intact uterus. It goes for postmenopausal women. Women who are younger, right? They may prefer a sequential therapy, and some of them are candidates for continuous sequential therapy, where there is a no break because they don't wish for a break. So women who are perimenopausal and have some kind of pain for example, they have endometriosis or some painful period. They can also have a waning estrogen, function. They may come with hot flushes. Then in them, they may prefer no break. Some women naturally do not like. So for them, continuous sequential HRT. And for women who desire a break, perimenopausal they are, or early menopause, they can take estrogen for the first 21 days and progesterone from day 7 onwards for 14 days and take a 7-day tablet break. One advantage of this kind of sequential is it reduces the total amount of, hormone given to the woman maybe in the long run. But in the short run, it doesn't not really matter much. Transdermal gel can be applied on the arm daily instead of oral. And dydrogesterone 5 milligram, as little as 5 milligram is enough to protect the uterus in women with interact uterus for 14 days. An alternative can be LNG IUS. Okay, so postmenopausal women, continuous combined is a very, very favorable thing. When the uterus is not present, the MHT seemingly becomes easy and we can give them continuous estrogen. So that is one broad overview I wanted to give, and we go ahead with the cases. Over to Dr. Joshi. Yeah.
Okay, so now we know that menopause management is symptom led, and it is we proper triaging with the age and risk stratification, and it is actually patient centered. So we will be taking few scenarios. In first scenario, this lady is 53-year-old. She has recently attained menopause at the age of 50. She have hot flashes. Maybe we will say, when we are talking hot flashes here, we are not talking about, we know three types of hot flashes are there. Mild, only little hot flash comes and goes. They get used to it, and it doesn't require MHT. Then grade 2 is with sweating. That is also sometimes patient can do away with it. But usually when we think to offer MHT is when the hot flushes is with sweating and palpitation. So grade 3 we are talking about. So she is having hot flush, night sweats and sleep disturbance. We know that Indian female have less VMF, vasomotor symptom, and more sleep disturbance. But she doesn't have any history of CVD. She is not diabetic. There is no history of cancer and no comorbidities. She is 53. So, and bad hot flashes. So, who is going to take this question? Is she ideal candidate for MHT?
Yes.
Yes, yes, ma'am.
Dr. Sugandha, please.
Since the age of patient is 53, less than 60 years, and the duration of menopause is just 3 years, with no history of any cancer or any comorbidities, with visible and a patient is having symptoms of hot flashes and night sweats. So this is an ideal case for starting MHT.
Yeah, correct.
So,
Go
which
ahead, go ahead.
estrogen molecule and which progesterone molecule? Because she is low risk, and what progesterone molecule? Because she has sleep disturbance.
Uh, the progesterone which we start is micronized progesterone or dydrogesterone can be given.
No, why? Why micronized and why not dydrogesterone when there is sleep disturbance? So,
Yeah, so
as we were discussing, for estrogen, she is a candidate both for oral and transdermal, both. Why we are still talking about oral? Because in 30% of the patient who are taking oral, they have vaginal lubrication also. In transdermal, there is no vaginal lubrication. Second thing, as it is I said, Indian females have more sleep issues, more sarcopenic than having vasomotor symptoms and all. Osteoporosis comes very late. So for such people, we should be selecting oral to start with. See, because just because transdermal is available, we should not be thinking to give it to everybody, because spray is expensive, gel people they do not like, and that whatever this is, patch is not available in India. So oral tablets, there are few females who are comfortable, and we as a practitioner should be in our kitty, we should be having everything. So oral, if she is asymptomatic and doesn't have comorbidities, and for the progesterone
in this
molecule,
case,
ideally,
just let us focus on this case, Madhuri. No
yeah,
comorbidities, we know already.
she doesn't
Yeah.
have comorbidities,
No,
so
nothing. We know
transdermal,
everything about the patient. We can
yeah,
give
so
either oral as a combination, or we can give
ha,
transdermal also, no problem.
so
Yeah,
in
yeah.
transdermal, and also in progesterone, sometimes for protection we may use intrauterine contraceptive device also, that
Yes,
one
yeah,
thing. So
correct.
we have to triage according to the progesterone also.
Anybody
We should,
has any
Actually,
concerns?
Madhuri, for
yes,
sleep
Dr. Bipasha
disturbance,
madam,
yes,
yes.
for sleep disturbance, I have seen micronized progesterone is better than
That's what
dydrogesterone.
I
Yeah, it
wanted to come.
causes
That's what I'm
drowsiness.
saying.
Correct, correct,
That's what
correct.
I'm saying. Yeah.
Micronized
So
progesterone is
she had
better.
told actually the correct thing only.
Yes. Yes, ma'am. Dr.
First
Bipasha, thank you.
responses, yeah, the first person
Yeah.
also. So this is very simple here.
Yeah.
We don't just jump on to the HRT. See, this is such a simple prescription. You know, it has all the components. We check her all the findings. We do basic investigations. You know, everybody does thyroid and glucose. I'm sure all your patients will be doing that, right? And then you tell them 5 times a week you exercise, otherwise this is not going to work for you. Resistance training, walking, everything you tell. And then protein diet also has been discussed. No, please discuss the milk products, cheese, and fruits, vegetables, etc. And avoid sugar, salt, polished rice. Okay. You have spoken about calcium supplementation. You have spoken about vitamin D, and there are some kind of guidelines to give vitamin D at least 1,000 international units. Some books say 1,000 twice daily. Some say 750 to 1,000 per day. But the bottom line is you have to give vitamin D along with calcium. And this is the hormone. And I think they responded correctly by saying 1 mg plus 5 mg. So, or this is the older prescription, the conjugated equine estrogen, along with either of the
Now we give
dydrogesterone or
estradiol. Now we
we
give
can give
estradiol.
estradiol. We
Yes.
give estradiol, yes. And since this woman has particularly described, as Dr. Sain excellently pointed out earlier, venlafaxine beginning at 37.5 milligram per day does wonders. So there can be slight conflicting thoughts in the mind whether we can prescribe an SNRI. Always you are free to consult a neurophysician, make it a multidisciplinary or a psychologic consult, but psychologic consult will not give you the prescription. So neurophysician can be approached, sleep disturbance can be looked into even better, right? Yeah.
Ma'am, I
Anybody?
would just like to add one thing.
Yeah,
Nowadays,
Monica?
I've seen physician giving magnesium to those who have sleep disturbance.
Yes, I
So
agree
I
with
think
you.
that
Correct.
needs to be explored, that
Yeah.
whether
So
magnesium can really
now,
help.
no, many
Can
preparations are
we
coming
also
up
ask?
now
Yeah.
where calcium is combined with magnesium. And I think it is a good strategy that newer products are coming up. So do look into those products and you can choose those products. I agree with you that magnesium has its benefits in sleep deprivation. This is some data about the benefit in hot flushes and those who still feel to be convinced. So I just wanted to just have one dialogue with Madhuri on this because
Yes, ma'am.
she said that you said that in the more severe types of hot flushes. But then I wish to tell you that this woman doesn't have isolated hot flush. No, this woman has the other works also. So if the hot flush is minimal, also I would prescribe. I would not withhold hormone therapy for her. So this kind of symptoms is a cry of the female body that she needs estrogen. Let us remember it as a cry of the female body that I need estrogen, I need estrogen. And when we were of this age, nobody was there to prescribe for me. So I would want to prescribe for women now. So this is something else which people told. A lot of things. So hot flushes management in other ways also, because some people are kind of very fond of doing something, so it takes their mind off. So they can wear layers of clothes, relaxation techniques, facial spray, cold pillows, so many things. Avoiding spicy food, yes, okay, and sudden temperature change should be avoided. Okay. So then, yes, Madhuri, all yours.
Yes, ma'am. Okay, thank you. So now this female is 50. Okay, there are no menopausal symptom, and but she is concerned about her long-term risk. So is MHT indicated in such patient? Any role of bone, heart, or any cognition for what to offer her? And what is the risk benefit assessment in a lady who is 50? There are no symptoms, but she is just concerned about the long term health. Who is going to take this?
Ma'am, should I
Yeah.
take it?
So
Yeah,
Yes,
yeah,
please,
Mini.
Dr. Mini.
Yeah, Mini.
Yes. Ma'am, earlier when we used to prescribe for such a patient, it was a routine that heart, bone, cognition should be taken care of, and everybody is supposed to be given MST. But now it is not so. We are supposed to give it only mainly for the symptoms. It is not a prophylaxis. We are not giving a prophylaxis to everybody. Okay, you are above 50, and just because of the age you are supposed to take this MST. It is not so. As she
Okay,
doesn't have
so
any symptoms,
yeah,
we
correct.
can give it.
Can I
Anyone
Ma'am,
else? Yeah, yeah,
No,
yeah, yeah.
even I would say that she does not really require. Dr. Mini rightfully said MHT is not a prophylactic treatment, and if she's so concerned about the bone and heart, she's already got a lifestyle modification, calcium tablets.
Yeah. I
So
Calcium.
think
that would
Dr. Pranay
Fukan
Yeah, yeah.
also.
Yeah, and at this actually situation,
Mm,
as she's concerned about her long-term health, we have to find out
mm,
whether she's a suitable case for MHT or not.
mm,
If she's a case of suitable case for MHT by risk, I mean, just ruling out all the risk factors, I don't think that she should be deprived of taking MHT for some time because it can protect the bone and heart in the future. So if the
okay.
patient is,
So
yeah.
she can be on
No,
follow-up. She can be
actually,
on
DEXA
ma,
scan
follow-up.
can be done
I
for her.
I beg to
Actually, we have to go
differ.
for, yeah, risk
DEXA.
we have
No,
to go
I
for.
Dr.
She's,
Fukan.
Dr. Fukan,
Dr. Fukan.
I
Sorry,
beg
Bipasha.
to differ. I beg to differ because we cannot, as Dr. Mini told, we cannot offer MST as prophylaxis. But on the contrary, she has come. She is concerned about long-term health, so we should offer her a good range of investigations
DEXA scan.
regarding her
bone loss,
general health,
yeah,
general
bone loss.
examination, pelvic examination, then USG, then mammography, pap smear, and all these things, so that, and lipid profile, especially lipid profile, thyroid profile, all these things which can come in this at this age. So and also DEXA scan, all these things, so that we
Yeah.
can identify any comorbidities which are common at this age. And so far
Yeah.
as she doesn't have any symptom, we won't offer her
Yeah.
image. But if
Yeah.
any
So, yeah.
treatment for comorbidity is
Correct.
required, we
Correct.
will offer.
So,
So
Bipasha, yeah, so it is a good thought that everyone is having that it is driven by symptoms. But I don't know why Dr. Pranay said that. But Dr. Pranay, this is the futuristic thought about MHT. So, in the years to come, I think there will be more evidence generated that in fact, without symptoms also, there is a role to play in women who have very high risk of cardiovascular disease in future or of osteoporosis. So as Bipasha said, if we assess because osteoporosis is also a very silent phenomenon. So if
Exactly.
Yeah.
we identify
Exactly.
osteopenia and
Yeah.
osteoporosis and she has
And
a reasonable
sarcopenia,
fracture risk, yeah,
Yeah.
osteopenia,
so
sarcopenia,
correct,
and
correct. They're
I
all
have some
silent,
experiences.
correct.
Some patients who are having
Mm,
diabetes mellitus, it is
yeah.
also being taken care of by the MST in some patients because at
Mm,
this
but
yes.
then
stage,
sir,
the
but
patient who
then
are
sir,
having obesity,
I
especially the
No,
central
right
obesity,
now,
yeah,
yeah, Pranay, but yes, I know what you're thinking. I can understand. But
mm-hmm.
we have a responsibility now, present in this webinar, to give the right message to the
Yeah,
audience who are just beginning to get their bearing on MHT because they are not yet, So
okay, it's
this
okay. Yeah.
field of prophylaxis for particular women as yet remains slightly on the research side. So today's webinar, we should convey simple things so that at least the prescriptions start rolling out. And And yeah, for this, we will one have fine print.
more
Discussion. Yeah,
Yeah.
correct.
Only one catch is there. There are no menopausal symptoms. But as Dr. Fukan said, to take proper history, if she has a history of rigidity fracture in a mother,
Yeah.
and if and on DEXA scan, as Dr. Bipasha
Mm.
said, to do the
Osteoporosis.
scan
That's
osteoporosis,
what.
then
Mm.
she
Yeah.
is a candidate. Then she
Candidate.
becomes a
Okay.
candidate.
Madhuri,
So we
let
have
us
Exactly.
go for the
but
third
for
case now.
symptomatic, there is no
Yeah.
nothing, as Dr. Shobha madam said. So now our third case is she is also 50. She has two kids. Her both normal vaginal delivery, but her BMI is on the higher side, and she's only 1 year postmenopausal. Symptoms are severe hot flashes, disrupted sleep, anxiety, body aches, fatigue, and her medical background: she is hypertensive on clinidipine. BP is quite controlled. HbA1c is on the pre-diabetic range. She's not a smoker, and she walks daily. There is a family history of the breast cancer, not mentioned about triple negative or what type, but maybe we can think as estrogen progesterone positive. So who is going to take what we should be offering her for her bad symptoms?
Yes, for
Agree.
family history of breast cancer is not a contraindication for MHT. But we have to be extra cautious and screen her whether she has BRCA this receptor positive things or not.
Mm.
If she is not having breast cancer but receptor positive, then we
Mm.
cannot offer her
करेक्ट विपाशा
MHT.
जी
We
एक एक
yes.
है कि ये क्वेश्चन को सब लोग यस और नो में आंसर करेंगे कैन वी
Uh,
प्रिस्क्राइब एमएचटी सेफली इन दिस वुमन यस और नो
Yes
I
or
think
no?
that if she is having
We need to
Safely,
such
no.
calculate the
capacity,
Yes,
risk.
The
with
word,
caution.
the word safely, if it's safely, then I would say no. But
No.
then,
Hmm.
yes, we can investigate her and we find out.
Yeah.
And also, she needs to be counseled. But the word safely, I would say no.
Ma'am,
and
No,
that
MHT with
I
caution.
think you
We
will
need to do
prescribe it
lipid
safely
profile.
only.
Only
That
thing
is
is
the
that
that is the
only
entire
point
skill. Yeah,
only
you
point
have
for
to.
no is a
No,
family history of
ma'am,
breast cancer,
from
nothing
us
else.
it is no. No, so many things,
no, no,
ma'am.
in
So
this,
many. Hypertension, obesity, diabetes, everything is
The
coming
lipid profile
together.
Hypertension
should
is
be
not
checked for
See,
this
specific.
woman.
we are in
Let
the
us
Hypertension.
see.
era of
Let us see. Let us see.
calculators. We will be using the decision will not be subjective, it will be objective. We do have
Objective.
risk calculators.
Yes.
exactly,
So,
yes.
so
We
do
have
we
risk.
have some calculators? And in our new guideline, many calculators have come up.
Yes.
One is ASCVD, and there are other Globocon and many other calculators to find out where she is, so we can triage her. So anybody want to
Okay,
talk
so
about
this
this
is, yeah,
ASCVD?
so,
So
yeah.
in this,
Hiteshwari?
yeah, in this we basically look for the age of the woman. Then we look for the BMI, cholesterol. That is, we look for HDL and total cholesterol, no, triglyceride. I mean to say,
Hmm.
the blood pressure, the range of blood pressure, the
Hmm.
diabetic status, the smoking status. So there
Hmm.
is a calculator which is available online
Yeah.
also. You
Online
can
it
put,
is. ACVD
yeah,
can be done online. As the woman is
yeah.
sitting in front of you, you can do it off. The only
And
thing
if it
is
is
you need
less
to
than
have her lipid profile. Lipid
lipid
profile is a
profile,
must.
exactly,
Yeah.
yeah.
Hmm. Hmm.
And if the risk
Hmm.
is less than 5%, then she is in the safe category wherein
Hmm.
we can give her.
Hmm.
If it is like between intermediate 5 to 10%, if it is more than 10%, then she is high risk.
No,
We
but
should
this
avoid give.
Hmm. Hmm.
cardiovascular disorders only. And she
Yeah,
Hmm.
also has
Hmm.
a
cardio.
Hmm.
family history of breast CA.
Hmm. Hmm. Okay.
She has some less history of family.
Apart from
And
family
so there
history
are
of breast
three,
CA, everything is okay. Everything is okay
yeah.
for MHT. Only thing is that family history of breast CA.
So
Otherwise, for her.
So we should be going back to these days new, like the new guideline have come up in Indian Menopause Society also have released one new guideline, and in that there are three calculators. One is that CRD, Southeast Asian Region D, that is which belong to us, that calculator, history and cholesterol. Second is that Globorisk, it is also lab and history proper. And third is for the small vessel disease, and that
Hmm.
risk calculator is Renault risk factor. All
Correct.
this may be Greek and Latin right now, but it is
Hmm.
in Indian Menopause Society calculator.
Hmm.
All of
Hmm.
us will go back and read and download them, and we can
Yeah.
use it.
So
So how are
this
we going to triage that is
correct.
the next question.
Yeah, so this cardiovascular disease risk over 10 years is by ACOG and AHA, American Heart Association, because they have done extensive work on this. So it's better to accept that because atherosclerotic cardiovascular disease risk score, if it is less than 5%, then and if the years since menopause is less than 5 years, then it is acceptable. So if are within this window, we will be able to prescribe her and see that it does not progress further, but it not as a primary prevention of cardiovascular disease, not as a primary prevention. That is the message we need to give. Women with established CHD, suppose we find a higher risk than she has established CHD, then statins should be given. And then no other things like we can try for vasomotor symptoms. What else can we try? I have put it here, but I would like the panelists to respond. What can we try? I put it here because she has come to you for help. You have to give her some help. You can't prescribe estrogen when the risk is high. So, what can you give now? Because remember, the family history of breast cancer was
Five to
a kind of
stations.
not a problem.
नहीं,
Was
একটা
not a
একটা
problem. The
webinar এ আছে
problem
No,
আমাকে
was
no.
the
পড়াতে হবে।
hypertension and her ASCVD
আচ্ছা
score.
ঠিক আছে পাঠিয়ে
So,
দিচ্ছি
the ASCVD score, if it is not permitting you to prescribe, then what else can you do? Anybody
Non-hormonal
can.
therapy we can
Not
try.
Yes. And
You have to give her.
phytoestrogen, stable on.
Yeah.
no,
Hydrocortisone.
phytoestrogen, Dr. Shobha Gudi madam very
No,
clearly said, still trials are going on. Phase 3 clinical trial, no phytoestrogen has
No
passed.
phytoestrogen.
All
But you
phytoestrogen should be in the diet, no tablets. But she is pointing out to one thing which is there in the
Yeah.
slide is CBT. Okay.
Yeah, so
Cognitive.
CBT has
Cognitive
helped.
behavior therapy.
Behavioral therapy has helped.
Actually,
And
cognitive
Yeah.
behavioral therapy is very good for sleep disturbance.
Yes.
Very
yes,
good.
yes,
Everything.
yes. And
Everything.
SSRI,
And also this
SSRI and
what Dr.
SNRI. Yes.
Dr.
SNRI also
Yes.
better.
And there is the
Yes,
new
yes,
one
yes.
which has come up
So
is the
these are all
stellate
important.
ganglion block, level 2 and level 3. We can look at that later on.
Yes.
So there are some non-hormonal alternatives. If it is contraindicated or decline, the first line non-hormonal options, and this is how it
SSRIs.
looks like. So as Madhuri correctly said, isoflavones, etc., are all complementary therapies because they will not directly relieve. They will only kind of be supporting from the side. So what you have to do is something like this. You have to either get a neurophysician along with you and try to prescribe an SNRI or SSRI, but don't withhold treatment because her quality of life is very poor when she's going through such symptoms. And cognitive behavioral therapy also, all of you have agreed. And exercise will help her. Weight loss will help.
It is coming in a big way.
Yeah.
Big
Okay.
Bull.
So in some women where oral estradiol cannot be given, even if there is a low risk of ASCVD, I think transdermal gives a way forward. We'll come to it. We'll go to this case.
Okay. Now she is 42. Okay. So she is menopausal since 1 year. But BMI is 24. She is a known diabetic, type 2. She is on oral antidiabetics. HbA1c is 6.5. No history of CVD, VTE, and no, she is non-smoker. But her symptoms are frequent hot flashes, insomnia, irritability, fatigue, reduced quality of life. So 42 age. Do you think in what category she comes? Is she
Early
premature menopause
menopause.
or she
No,
is?
no, not
Early
premature.
menopause.
It
Early
is early,
menopause.
not
That's what.
premature.
Early
Early
menopause.
No, not
Yes, that's
premature.
what.
Early menopause.
So, somebody please highlight about this early menopause and about this how to
Actually,
go about her
early
treatment.
menopause means beyond 40 years, but less than normal
50
menopausal
maximum.
age, less than 46.5 or 47. That is early
Perfect.
menopause. And if it is before 40 years, then it is premature menopause.
Yeah, just discuss off the glucose
Very
metabolism
good.
thing because so
Hmm.
many women are diabetic today. So we thought that it is pertinent to put this case. Yes.
Yes, actually, estrogen,
A
she is
very
an
perfect case.
ideal patient for MHT. Actually,
Yes.
I
diabetic
agree with you. Correct.
estrogen is
Improves the insulin.
positive, improves the
Yeah, correct.
glycemic index and all these things.
Dr.
But
Fukan has been telling us
yes,
from the beginning that it is
uh,
improving glucose
yes. But
metabolism.
True,
she
true,
her
true. Absolutely.
HbA1c is high. Everything
Yeah.
it will be taken care of, and she has got hot flashes, insomnia, irritability, fatigue. Everything will be taken care of by MHT.
Therapy.
Only thing, if it was type 1 diabetes mellitus, then we
Then
had
it
to
should have
think
been dangerous.
otherwise.
Yeah.
So this is the hers and
Ideal
Dr.
case
Vijay.
for MST.
All of them are supporting it. And more than 60 years, we need not go. More than 10 years, we need not go. High CVD risk, we need not go to MHT. But
But
otherwise,
nowadays, for more than 60 years, we can
we
continue
can think, we can think. If they
with
have been
proper
doing well, we
evaluation,
can, yes,
proper
with the
evaluation and all this.
yes, 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 yes. We can have some exceptions to the rule. As I said, Bipasha, there are a lot of extensions of therapy now. But then,
Yes,
today our duty is to give the message to those who
yes.
are beginning to prescribe. So, yes, Madhuri.
Yes, ma'am. So this I would say girl only, 34-year-old. She is
Yeah, girl.
married. She has only one kid. She has amenorrhea of 10 months. Her BMI is only 22. She doesn't use any contraception. She is not on any chemotherapy, radiotherapy, and she presents with hot flashes, severe night sweats, mood changes, anxiety, sleep disturbances, vaginal dryness, and reduced work performance and quality of life. So, how are we going to evaluate her, and what are we going to offer her?
Hello, it is to be
SSH.
considered as a
This is a
premature
case of premature
menopause.
ovarian insufficiency, and she needs.
Yeah.
Yes.
Yeah.
So
Okay.
Yeah.
we
So
will
basically,
prescribe,
FSH
right?
needs to be checked on two different occasions. It should be more than 30, at
Yeah,
least 4 to
correct.
6 weeks apart.
Yeah. Yeah.
So
So,
yes,
how are we
definitely
going
we
to
need to
treat her?
check. Yeah, we can
Yeah, we
Actually,
will
discuss about
definitely
it.
give her estrogen and progesterone.
she needs higher
dose of estrogen and progesterone, 2/10 actually, 2 milligram estradiol and
Yeah,
10.
correct.
Yeah, that is the thing
Yes.
until the natural age of natural
Natural
menopause.
If she is hypertensive, will you be giving it?
Yes, yes.
Yes.
So there
Yes,
lies a
Well
catch here.
controlled.
it improves
Well
improves
controlled.
lipid
Should
profile.
all the more
Very
reason
controlled.
to keep the
Not
hypertension
coronary
well
arterial
controlled.
disease, not
Yes.
coronary arterial, but
So
hypertension is yes
Big
for
control, of
MST.
course. Yeah.
and
So see,
because
I am
there is
very optimistic.
sometimes
This woman doesn't
yes
have. She's only 34 and she's non-hypertensive.
yes
So let us
no,
have
but
this
sometimes they have
Yeah, I
autoimmune
know.
Yes.
Yeah,
disease and
correct,
No, we
correct.
can give.
like
We can
Yes,
give.
true.
yes
True.
yes
There
but
can
some,
Actually,
it
it will
can
be.
be due to some reason. So in such women, since you brought in the subject of autoimmune disease, premature
yeah
menopause is not a simple condition. And
yes
sometimes they have other autoimmune problems for which they require actually evaluation every
Very
2 to 3 years, right?
So
Because I
this
think
lady
those
might
who,
be, no,
yeah,
this lady might go for
Actually,
even ART also, no? She might be
yes,
trying
she
for a
may go
second
for
no,
kid.
we
ART.
do not
Yeah,
know.
So
actually,
we have to keep the uterus probably,
yeah,
you know,
yes,
just
correct.
favorable
Healthy.
estrogen
size so
Also,
that,
estrogen
yeah.
helps hypertension in two ways. It
mm,
increases the nitric oxide synthase enzyme. So nitric
mm.
oxide is increased and vasodilatation is there, and it inhibits the endothelin 1 enzyme, which causes vasoconstriction. So estrogen portion is good for hypertension patient.
Yeah
This
yeah
natural estrogen, the
Yes, yes,
estradiol, the
yes.
yes
estradiol,
Estradiol. I am
yes
not
always
ethinyl
telling you.
estradiol,
so
estradiol.
Yes,
Okay.
yes.
yeah
All
Dr.
right, all right.
Bipasha
So,
is really very clearly said कि deficiency of estrogen is inflammation which causes endothelial
yes,
dysfunction
yes.
Yes,
so
yes.
correction of estrogen but if and as Dr. Fukan said कि if she wants to become pregnant but what if she doesn't want to have a kid so can we
Hmm.
give some contraceptive pills to her and is
Uh,
it
That would
equal
be
to
a very
not
MHT?
nice
for
treatment
no,
for her.
not
No,
No,
see
HM.
earlier.
No,
No,
no, no, no.
earlier that option was there. Even
yeah,
today,
yes.
like
Yeah.
girls with Turner syndrome and all, they cannot afford the HRT of long duration. Sometimes they socioeconomically, then we consider giving
We
them
give
those
OCPs.
estrogen.
We
Yes,
can
we
use
give them.
LNG IUD in such case, no? They can, it
But
can help
it
with
is not an
contraception.
LNG will
ideal
not
thing.
give the estrogen.
And
LNG
she
will not
needs
give the
Along with
estrogen.
estrogen.
estrogen,
OCPs we
along
can
with
try.
estrogen,
Yeah, we can
OCPs we
do
transdermal
can
that.
try
For
in
estrogen.
these
this,
patients.
Yeah.
yes, we can do that. We can do that. Go for this case.
Okay.
Yes. Mm.
Okay. Now this lady is 49. She is menopausal since 2 years and she has severe hot flashes, night sweat, sleep disturbance. But she has an unprovoked DVT 5 years ago. Her BMI is on the higher side. She is non-smoker, not on any long-term anticoagulation. So how are we going to manage her now? Bad this
Oral estrogen will be definitely
Since
Yeah.
symptoms.
this,
uh,
She's at quite high risk.
Well,
since this patient
she's a
is
high risk.
Not as a first option.
So she's a
Yeah.
high risk
So,
for oral estrogen, definitely.
mm,
So
mm,
either we have two options. If she has problems, we can for the bone problems, then we can even go for tibolone, or else you
mm,
can try transdermal patches.
mm.
Or we can go for
Um,
non-hormonal options.
Okay, I think,
Non-hormonal.
Non-hormonal options.
yeah, I think I would also go for some non-hormonal in her.
Hmm.
And if it is not working at all, then I might consider. But then I
Non-hormonal,
would prefer non-hormonal in her.
No, no.
non-hormonal
Though
for
there
hot
are,
flash.
correct,
Yes.
correct. Though
Night
there
sweat.
are, because let us remember that Caucasians have a slightly higher risk of actually thromboembolism disease. But in them, studies have shown that transdermal actually does not increase the risk because it bypasses the liver, which is where all the coagulation factors are generated with estrogen stimulation. But so, therefore, transdermal is okay. But even then, I feel that, it will be important to go for non-hormonal first as a duty towards her. Now, this Madhuri, I think we will take this as the last case because I think there is one more topic. So we'll take this as the last
Yeah.
case. After that, I shall conclude.
Yeah.
So you please take it as
Okay.
the
Okay.
last
Okay.
case. Yeah.
Yeah. So this lady is 51. She is menopausal since 3 years. She has estrogen receptor positive breast cancer and she has completed surgery, chemo and radiotherapy. And on previously, she was on tamoxifen on aromatase inhibitor. But she is having now hot flashes, night sweats and vaginal dryness. And how to manage her now, these symptoms? Yes,
Only
Dr.
Full
Fukan.
vaginal.
non-hormonal.
And they said
yeah, she should get actually oral little difficult.
Hmm.
In some cases, of course, the vaginal estrogens can be
Vaginal, yeah.
tried. Yes, vaginal.
But
No, but
always
hot flashes,
Sorry,
is there.
Non-hormonal
Hot
therapy.
flushes don't
hormonal.
respond much to vaginal estrogen.
Non-hormonal
Non-hormonal
therapy.
therapy along with
Ma'am, we
vaginal
may have
cream.
to go for non-hormonal therapy only in this case because it is
Yeah,
obviously safer in this patient.
safer.
And among the non-hormonal, we should avoid paroxetine here because
Yeah,
she was on tamoxifen. We should avoid paroxetine. Apart from
Very correct,
paroxetine,
very correct.
yeah,
So let me
because
just
of the
complete
enzyme
with
induction.
correct, correct, correct. So let me just complete with this slide. Excellent input by the panelists because this is a very complex area of practice. That woman has had breast cancer, has been treated, and you know what else the miracle can happen than getting treated and being cured of breast cancer. That is a really a second life, like a rebirth for the woman, and we should not jeopardize that in any way. So they do experience early menopause due to adjuvant chemotherapy or sometimes bilateral oophorectomy, which has been done. They will have vasomotor symptoms, which is due to tamoxifen therapy as well. You know, that also adds on. So aromatase inhibitors may also cause hot flushes actually, but they tend to be less frequent and less severe. So in women who letrozole can be considered instead of tamoxifen for the prophylactic therapy for preventing recurrence. Lastly, in women with history of breast cancer, systemic estrogen therapies are considered relatively contraindicated.
Indicated.
Okay, as a standard contraindication, not low dose vaginal estrogen, systemic is contraindicated. So, data from Habits trial says that they do not recommend estrogen, and other established means of controlling symptoms or preventing osteoporosis should be utilized in these women. So, all the panelists have given a very good answer. Let us go with that. And I'm very sorry that we cannot continue
Finish
the
all the
panel any
cases.
longer. Yeah, yeah. Maybe some other time we shall
Hmm.
do the GUSM, etc., and the osteoporosis because the panel is excellent. I hope that the same panel comes together some other time. I'm very happy with the panelists today. Excellent responses. Thank you very much. I must just
Ma'am, if
conclude
you
with
can,
this
ma'am,
these
can
few
you please
questions. Yeah,
just put two
yeah,
words
these
about
questions.
tibolone or ormeloxifene, or
Okay. No,
if you can just
ormeloxifene is
touch
not
them.
available, so I'll definitely put for tibolone. Not a problem. Ormeloxifene not available. Let us not spend time in
Fine,
what is not available. Yes, please. Yeah, tibolone in
tibolone.
menopause. Who benefits the most? You can respond, Mini,
low libido,
because
low
you're
libido,
yeah,
low
yeah.
libido.
No, Mini wanted to say something because
No, ma'am,
she
I
must
just
have
wanted
had.
to
And
touch this
if
as
it
Yeah,
is
well.
an
please.
I mean,
osteoporosis,
we have been using tibolone very often. I mean,
Hmm.
those who actually do not get benefited by the other methods, we
Hmm.
usually take them to tibolone. However, it is difficult for them to get it in such a place, but they still are very happy with tibolone. So I just wanted you
Yes.
to touch about tibolone as
Yeah.
well.
Yeah, yeah.
I want to say only
So
two lines about tibolone. Tibolone
yeah.
is actually all in one, but patient should be definitely more than 1 to 2 year postmenopausal because
Yes.
bleeding may come in. Second thing
Yes.
is that they are at the risk of vasomotor symptom also. Third thing is that Serum Institute of India ka Cibolone is only one-fourth the
Only brand.
one-sixth the charges of that our Livial.
Okay.
So
That is good.
availability of Serum Institute products
Yeah.
are
Yeah.
very good, and
Very wonderful.
but we have to really keep same contraindications are same. Max to
Uh,
max use 3 years, and gradually over the time we can stop and try, and long term
yeah.
again it can be used again. But
Correct.
it is really very much good for breast density. That is one good thing about it, and it causes, as Dr. Bipasha said, vaginal dryness is and mood elevation is there. So as Dr. Shobha madam said, it was really very good panel. This menopause is actually whatever we have touched upon is nothing. We have to really, her menopause prescription writing modules are available,
Mm.
and we must really revisit them. And today I'm going to talk about the CIMP examination, and Dr.
Yeah.
Sushma
Just a minute,
Verma
माधुरी.
madam is there.
माधुरी
That
मैं
later
खत्म
on.
कर दूं
हाँ,
थोड़ा सा
खत्म कर
पैनल
दीजिए.
खत्म कर क्योंकि
Yes
सीआईएमपी
ma'am.
को अलग से बताना पड़ेगा इसको मैं
Yes,
खत्म
ठीक है.
कर देती हूँ
Yes
ठीक है
ma'am.
ना
Yes ma'am.
तो
Yes ma'am.
Tibolone, as
thank you.
many of you have a very good experience, it is looking like that they are especially suited for women who have symptoms, especially sexual desire symptoms and other problems related to it. Sometimes there are relationship problems as well.
So this particularly benefits women who are having a very hard time in that segment, and also a risk for osteopenia, etc., and who also have more breast symptoms of high breast densities. So in them, it benefits more. It benefits more. When we give tibolone, we don't usually prescribe a progesterone along with it because tibolone has progesterogenic properties as well. That is how it goes, but it does not have as robust evidence as the estrogen and progesterone has. So, still it is an evolving therapy. Libido, mood, breast tolerance, or bleeding patterns limit the conventional MHT. So, when conventional MHT is poorly tolerated, tibolone is an answer. Okay, so I think with that, let me just highlight the risk of breast
बंदे को
cancer,
फोन आ रहा है
which
जब मेरा खत्म हो
people
रहा
are very,
है
very afraid. Because if you ask a general practitioner, what is your opinion about MHT, he is likely to say, "What? Give hormones to older women, she will develop breast cancer." And this is the kind of buzz which
उनको
people
फोन
have
लगा
about
बोलो
hormones. Please mute can have about breast cancer, the fear of breast cancer. So we have already discussed about MHT in breast cancer survivors. Now we must think about whether what tell women and how to placate them about the risk of breast cancer. So in general, what has been thought is the risk of breast cancer in women after 50 years associated with MHT is actually a complex issue. Well, the decreased risk reported from RCTs for estrogen alone. So whenever we give progestin, especially the medroxyprogestin, which was used in WHI, then there is an increased risk of breast cancer. The current progestins are actually safer. So the specific progestogen used is what caused it. Okay. In 2016, the increased risk again was attributed to MPA, and it will be lower with micronized progesterone or dydrogesterone. So let us assure in that way. Okay. And we are going to evaluate the breast cancer risk before MHT prescription. And if we find that there is a particularly high risk, then we might consider something. I love to put this slide. That is why I requested permission to conclude, because I wanted to show this slide. Now, this is from MHT, British Menopausal Society, 2016, and I'm very thankful to them for putting this. And if you can see that they have checked the breast cancer in these 1,000 women, 50 to 59 years. Okay, 23 cases were there in those 1,000 women. And when they evaluated the cases, they saw that those women who took hmm, combined MHT, there were four more cases. That means progesterone along with it. In estrogen only MHT, four fewer cases. Obese women, 24 more cases. Alcohol more than 2 units, five more cases. Combined hormonal contraceptives, four more cases. Current smokers, three more cases. At least 2.5 hours moderate exercise per week. Just 2.5 hours moderate exercise per week. Seven fewer cases. So can you see that the risk is not, no, should not attributable to MHT. It is the lifestyle and the BMI which determines more. And estrogen alone therapy or even MHT with the current newly available progesterones, the risk is much less. So with that, I think these are the indications for transdermal. I think this we will keep it for another time. And yeah. I don't wish to, uh, sorry. I just want to finish by saying that don't miss the MHT Express. Okay, please prescribe. And a young woman is a gift of nature, but an old woman is a work of art. So let's just preserve the art. Thank you so much, everyone. Thank you so much. Thank you.
Thank you, everybody. Sorry we
It's
delayed
really
the
a
talk.
very good panel discussion.
Thank
Thank
you.
you, ma'am.
Excellent. Very
We
thoughtful
really
and
have
very.
a part two for this. This is just part one. We'll have a part two. What you say, Dr. Archana, madam? We need to have a part two because after seeing those slides, I can't sleep tonight with rest.
I know. I think it was a mind-blowing panel by
Right.
both of them, and all the panelists were superb. I
Right.
think it's a totally new arena, isn't it? So I really enjoyed listening. So congratulations to all of you for wonderfully participating in this panel. Thank you, Dr. Shobha.
Thank you.
Where have you gone? Shobha
I'm here.
Okay.
Just
Thank
beside
you
you.
so much.
Thank you all.
And thank you. Thank you so much.
Thank you, Dr. Madhuri ma'am. Also, thank you very much for accepting to become the moderator at the last minute. We express our gratitude.
Pleasure. Pleasure is ours, mine and Adam's. Thank you.
Madhuri ji.
Thank you.
Yes, Dr.
It was a
Can you take over?
discussion. Dr. Zaidi took an engaging panel discussion on prescribing practices in menopause. It was guided seamlessly by moderators Madhuri ma'am and as well as Shobha Gudi ma'am. And the panelists brought tremendous depth of knowledge, practical wisdom, and real world clinical perspective to the discussion. I would like to invite Purnima Satuskar ma'am for some expert comments.
Am I audible?
Yes, we can
I
hear
am
you.
not able, I am not visible in the screen. Myself, Dr. Sushma Verma.
हाँ मैम आपका
You are audible,
you're
Sushma.
audible
But I am not able to see myself in the screen. That
You have to open your camera. You have to your video is coming across. So you go on your video and just press it once.
but मैडम का यहाँ पे वीडियो भी ओपन ही है.
video is open, ma'am.
Yeah, ma'am, I'll just check with the
technical team, but
I'll
Just
check with
check
the
it.
Meanwhile, Dr. Anjum or Dr. Bhagyashree, please take over.
Yes, yes. Can I invite Dr. Purnima Satuskar ma'am for comments, for expert comments on this topic?
I think ma'am has left, right? Not there.
Okay, ma'am.
Madam tried to join, but she was unable to because of the poor signal. So she has given her best wishes for our program today.
I think we can go ahead with the talk now, right?
Yes, we can go ahead.
So next, we would like to start our new topic, going ahead with the scientific program about establishing menopause clinic. I would request the CVs of the chairpersons, please. Sushma Verma, ma'am.
Some arrangement so that I could be visible in the screen.
Yes, ma'am.
Am I audible?
Yes, ma'am.
Yes, madam. You may give your inputs. Yes, please.
Okay.
Yes, ma'am. I would like to invite Dr. Sushma Verma, ma'am. Ma'am is currently the consultant and director of Sarvodaya Hospital of Test Tube Baby Center. Ma'am has also been a national chairperson and CIMP exam committee. Ma'am is the vice president of Raipur Obstetric Gynecological Society. Ma'am has also been the secretary of Raipur Menopause Society, organizing chairperson of 2 annual state conferences.
Hello.
Madam,
And ma'am also has award of IFS Achiever Award in
हाँ ये हो जाने दीजिए फिर
2024 at Ahmedabad. Ma'am also has 3 publications and ma'am's expertise in high-risk pregnancy, infertility and assistive reproductive technique. Thank you so much for joining in, ma'am.
Thank you for the kind introduction.
Next, I would like to invite Pragya Chaudhary ma'am. Ma'am is consultant infertility specialist at New Life Test Tube Baby MGM Research Hospital at Patna. Ma'am has been the president of Patna Obstetric Gynec Society. She is also the immediate past secretary of General ISOPA. And ma'am is the ICOG governing council member. Ma'am also has multiple awards, including the Asia GCC Award and Healthcare Professional of the Year in Bihar. Thank you so much for joining in today, ma'am. Next, I would like
Thank
to
you.
invite Seema. I'd like to invite Seema Vijayvargiya, ma'am. Has 40 plus years of practice. Ma'am has 51 Most Influential Women Award in Indore. Ma'am is the director of Shakuntala Devi Hospital and she's also the president of IMS Indore, past president of IOGS Indore, coordinator of Sangini Breast Cancer Support Group and master trainer Dhira Indore chapter. Thank you so much for joining today, ma'am. I would request Pragya Mishra ma'am to please introduce our speaker, Taruchaya ma'am.
Welcome, Pragya.
Yes. Can somebody display? Yes. First of all, at the outset, I would like to thank Dr. Archana Baser for having invited me for this webinar series, which is totally her initiative as the program director. So, and also AICC, RCOG West Zone for having involved me for such a wonderful webinar, which is just dedicated to menopause and menopausal symptoms. So, I would like to, it's a privilege for me to introduce Dr. Taru Chaya, who is a senior consultant in obstetrics and gynecology at Jaipur. She is the director of Bansal Hospital and Honorary Secretary Narchi State Branch Rajasthan, Vice President of NIGF, President-elect JOGS, and West Zone Coordinator of Breast Committee FOXY. So over to my co-moderator, co-chairperson for introduction of the Taru Chaya.
Welcome, Dr. Taru. I think.
Thank you so much, everyone.
And
I
you
think I
can
should
start your
not delay
topic.
it
Yeah.
and start my talk. And very much grateful to Dr. Bhasair and Madhuri Joshi for inviting me. And I'm making it full screen. Everybody is able to see properly?
Yes, ma'am.
Yes, ma'am.
So now your panel has made my job very easy because now everybody know what to do and what not to do and how to open a menopause clinic. So it is very important to know how to open and how to establish a menopause clinic. What should be our aim regarding this? Enhancing women's health through a specialized care. Globally, 25 million women experience menopause annually. By 2030, over 1.2 billion women will be postmenopausal. So what is menopause? We know. It is a natural cessation of menstruation, typically occurring between ages of 45 to 55, signaling the end of women's reproductive phase. So, what is the importance of dedicated clinic? It is usually focused under one roof for the care of climateric and geriatric women, specialized for unique challenges from perimenopause to the golden years. So our goal is to create a supportive environment offering evidence-based care for menopausal women. एक छत के नीचे हमको सारी प्रॉब्लम्स का सॉल्यूशन मिलना चाहिए. These are the goals one by one. Clinical objectives are like to provide accurate diagnosis and effective management of symptoms. Whatever symptoms we are having in postmenopause, they have to be diagnosed properly and managed. Prevent long-term complications like osteoporosis and cardiovascular disease. Then educational objective is equip women with knowledge about menopause. Because when the woman knows in details about menopause, then they can take care themselves also. Debunk myths and misconceptions. Always clear them out. Now, community impact is there. Improve women's quality of life. Wherever they are moving in, the quality of life should be good. Reduce societal and workplace challenges associated with menopause. Planning should be like existing resources goals and refinement of accessibility to a target population. Which population are we targeting? And we have to take care of that population. Then planning feasibility study. It assess population demographics. We have to assess what type of population is around us and identify demand through survey or focus groups. We should look for that what type of people are living around us, what type of OPD we are going to have, and we have to plan accordingly. Then whatever we are opening a menopause clinic, it is not for only charity. So there has to be some business plan also. So define mission, vision and core services. Identify funding sources. कहाँ से हमको मिलेगा money establish करने के लिए. Either government is aiding, NGO is aiding, or we ourselves are the private investors for that. Create a sustainable budget for this. Then select a proper location. If you are in urban or suburban, then near transport hubs. Space for consultation, education, and minor diagnostic tests. It's basically for who are opening only solely menopause clinic. But if you are opening in your own hospital, then you can just make a space for consultation because everything else is there only. Then what is the level of care? There are two levels, primary care and multidisciplinary care. Primary care unit is that when the premises are waiting area and consultation chamber is there. Core committee team contains gynecologists and paramedics. Ancillary team is visiting other specialties and instruments are there. So this is a primary care. When everybody can have in their own hospitals, if they are solely a small hospital setup, then primary care unit is your part. Dedicated days we can keep for menopause clinic, not every day, to avoid mixing with other patients. You are having antenatal patients also, so you can keep dedicated days. Consultation chamber can be the same, but you can change the decor according to the day. It should be well lit with positive vibes. Waiting area should be well displayed with educative material regarding menopause. The team should be receptionist, paramedic nurse, lab assistant, you yourself consultant, assistant consultants if you can, physiotherapist, dietitian, and psychologist. These are the instruments which you have to have in your clinic, like weight machine, BP instrument, measuring tape, because you have to measure your waist thickness, stadiometer for height, BMI chart, speculums for various sizes, glucolidine acetic acid, pH sticks, PAP sticks, BMI chart, and ultrasound, if that is optional. And what about multidisciplinary care unit? When you are in such center, the same as primary care, except there are chambers for other specialties like endocrinologist, general physician, cardiologist, orthopedician, radiologist, urologist, ophthalmologist, psychiatrist, dentist, dietitian, and physiotherapist. And added instruments can be sonography unit, X-ray, DEXA, mammography, hysteroscope, and particularly to other specialties. What is essential for both the levels? Documentation, record keeping, and internet services. Internet should be there so that you can keep your records online. Documentation should be there properly. And what are the optional things? Are affiliated services like aesthetic care, hobbies, and occupational care. We can teach them hobbies, or you can keep as a separate person for who can teach them what they can do at this level. It's basically a teamwork. Staffing requirements like gynecologist's expertise in menopause health, she should be well versed in menopause and hormone therapy. Nurses and midwives for patient education and routine care. Dietitian and dietitian can guide on which type of diet and bone health is important and which type of diet is good for their bones and muscle mass. Physiotherapist should be there to teach routine exercises and pain management.
Yes, he said he will send something in my WhatsApp.
Psychologists and counselors are also needed to address anxiety, depression, and mood swings. So, what is infrastructure and equipments? We've already explained about layout, like comfortable waiting areas, room, diagnostic center. This is already explained. So this is a menopause pro forma. We should have this pro forma with us. Everything is explained in this, and we have to get it filled by our staff or anyone helping. So we should know menopause symptoms. So already before the patient comes to you, this pro forma and symptom chart should be filled up in front of you. So services offered are clinical care, management of all symptoms, sleep disturbance, and vaginal atrophy. These are the main important common questions of the patient. Where hormone therapy is needed or not, or what are the risks and benefits of that, we should know so that we can explain to the patient, and non-hormonal therapies as well. Lifestyle support is very important. Dr. Shobha Guri explained everything. Whatever it is there, at last, lifestyle is only going to help them. Exercise programs for bones and cardiovascular health, nutrition plans, and preventive screening is very important, like DEXA, mammograms, and cardiovascular risk assessment. Mental health support and educational workshops like topics like healthy aging, coping with menopause, managing symptoms. Every different अपने OPD timings में we can make different topics so that we can discuss with all the your patients together. We have to tell them regarding breast health, self-examination, clinical examination, and mammography, cervical screening, pap smear, and colposcopy in perimenopausal phase patients, and management of postmenopausal bleeding. It's very important. We have to teach them if this is important, and immediately you have to tell to your doctor nearby. What are the assessments? Breast, already told. And apart from self-breast examination and clinical, there is a Gale model allow us to estimate women's risk of developing invasive breast cancer over 5 years up to the lifetime. We have to take history in details. Cardiovascular risk, we have WHO, and International Society of Hypertension. These are the two charts by which we can predict what type of risk patient. So we have to keep these charts in our clinic. Osteoporosis screen by FRAX screen and osteoscope. We have to keep these charts. We can immediately come to know where patient is having low risk, medium risk, or high risk. This is FRAX score. And sarcopenia screening is SARCF by strength, walking, chair rise, stairs, and fall. We have to look for all these symptoms. So very important is this community education. We have to do outreach programs, awareness campaigns, local media, social media, and community networks. We can collaborate with women organization, NGOs, and primary care providers like ASHA workers. Workshop and seminars we have to conduct time to time. You can take sessions in schools, workplaces, and community centers. Digital engagement is important. We are in now digitalized era. Develop a website or app with resources so that patient can come to know where and when and how to go to such clinics. See what is the operational outflow. Workflow is step 1, online, offline appointment booking. You have to book. Then number 2 is registration and initial health screening. Number 3 is detailed consultation with the gynecologist. Then whatever tests are given, then diagnostic tests are done. Then according to them, treatment plan is suggested and follow-up scheduling is important. And सबसे important is feedback mechanism for improvement. Feedback is important so that we can improve for our clinic. So quality assurance is important. Patient feedback is this for quality assurance, regular survey on satisfaction and outcomes, and symptom improvement rates, number of women educated on menopause. Professional growth is important, staff participation in conferences and training, And annual reviews of services, finances, and clinical outcomes is necessary because your clinic is successful or not, you have to come to know. So, what are the challenges and solutions are for challenges? Awareness gap is one challenge. So, what is the solution? Launch targeted campaign with relatively content. Your content should be good. Financial constraint is a challenge. Then seek partnership, offer tiered pricing, and implement a sliding free scale. Scale should be little lower, then you can have financial constraint, but we can overcome it. Then HRT misconception is a challenge. The solution is to educate through evidence-based workshops and one-to-one counseling. Prescription writing is very important in your clinic. We have to write everything regarding age, weight, birth, species. These are parameters and years of menopause, whether it was surgical and natural. We have to point it out. Then history of comorbidities, family conditions, clinical history like lifestyle, diet, sleep pattern, genitourinary symptoms, hormone therapy in past, or any medication, whatever she is taking now, like hypertension or diabetes. And what are the symptoms she is feeling? What investigations you have advised or what investigations are already done. We have to point out those also. And management plan, what is your plan and what already she is taking. Then counseling needed and what type of counseling. Vaccination in old age, mainly basically in case of fever, the annual vaccination or pneumonia vaccination, you can advise and follow up. So conclusion is menopause clinics address clinical critical gaps in women healthcare. Holistic multidisciplinary approach improves patient outcome. Join us in transforming women health by supporting and establishing menopause clinic in our community. Thank you so much. I've
Thank you,
just
Dr. Taru.
simplified this.
Thank you so
Everybody
much.
knows how to do it, but important points I have highlighted.
Thank you, sir, Dr. Taruchaya, for a wonderful and very comprehensive lecture on setting up of menopause clinic. And we all know that menopause is a natural transition in the woman's life, and many women continue to suffer silently because of lack of awareness and hesitation. And there is lot of hesitation in seeking help, and there is no proper clinic available whether a woman can go with their complaints. So, a well structured menopause clinic will provide a comprehensive care addressing the physical, psychological, social, metabolic health concerns of the midlife woman. So, very nice lecture, and you have all fulfilled the objectives of this lecture. And I think in every gynec, in any hospital and in every hospital, we should have a menopause clinic, because when we label it as menopause clinic, or we can keep a day addressing these women, because when we keep a day, or we can have a OPD on a particular day or date, then women sitting in the OPD waiting in area along with their daughter-in-laws, they can seek help of these clinics. So very nice lecture, ma'am, and definitely whosoever is watching this webinar and hearing all the lectures will definitely try to open a menopause clinic, or at least give a dedicated day to menopausal women in their OPD. Thank you so much.
I want to add here that we can start a menopause clinic if we have a qualified degree. And luckily, we have chairperson of CIMP examination, Dr. Sushma ma'am. And Abki Bar 500 par is our motto. Last year,
Yes, ma'am.
211 people passed this examination, very simple examination. Even after this one lecture, anybody can get more than 80%. So, Dr.
Yes,
Sushma
ma'am.
Verma, madam, will post the link of the CIMP examination. We will be getting 1000 page book free if you register. cost of the examination is 6,000 rupees, and she is the chairperson, and she is going to make it very crisp and very great so that we will get empowered to start a menopause clinic. Thank you.
And I formally invite you, all of you, to CIMP examination. And this is a certification course, and it is an excellent opportunity to enhance your academic credentials, strengthen your knowledge and midlife health. And this, as Madam already said, this is an online exam, and the tentative date of exams is 6th of December. But IMS membership is compulsory for this exam. And once we close the registrations, then we will be having classes on the most common and most important topics of this of the menopause. All interested members has to apply for the CIMP exam after completing their formalities for membership, and to avoid any delay in the application processing. And let's, all of us whosoever have not given the CIMP exam, participate enthusiastically for this exam and encourage their colleagues and friends and juniors to give the exam, because it is very important for to read about the midlife and menopause. And rest of the things Madam has already said. We will be after the registration, we will be providing the books, we will be having classes, and we will be having 3 or 4 practice sessions for the exams. And it is an online exam. Anybody can give the exam from anywhere. So thank you.
I
Thank you
want to
so
add
much.
one thing to this. I want to add one thing. This exam is not just an exam. We have already cleared it, but this is a learning process.
Yes,
When
ma'am,
you read
definitely.
this and you read that, you know everything regarding menopause. This is very important to do, because that is why it is very important to take the exam.
Yes, ma'am. It is a golden opportunity. Once you start reading about this midlife, anyone, once she starts reading about the midlife, then we will come to know how much is there to read and how much is there to learn about the midlife and menopause. So I request all of you to give the exam, register for the exam, be the member of IMS, and encourage everyone to give the exams and become a member of IMS. Thank you. Thank you so much.
Thank you,
And
ma'am.
thank you so much for the opportunity for giving.
Yeah. Dr. Anjum, thank you for having invited me to this AICC RCOG West Zone webinar. And as Dr. Sushma was saying, I'm sure a lot of people, most of the viewers would have benefited from the panel and from the lecture. The cases were also very good, common some scenarios that we come across in the clinic. And the lecture also by Dr. Taru Chaya regarding setting up of a menopause clinic was indeed helpful. We should have a dedicated menopause clinic, just like, we have a dedicated preconception clinic. So something like that. So thank you so much, and I wish you all the best for future webinars, and wish Dr. Archana Baser as well for her future endeavor.
Yeah. Yeah, actually, Pragya, I also joined again to wish Archana all the very best, because I have known Archana for so long now. Where is she? I can't see her. Has Archana left already? Yeah. So,
Amitabh the, just I think she must have
She has just
acha,
left.
call or something.
acha, okay, okay.
Your panel
I
was
just
very
wanted to
good.
wish.
Your
Yeah,
panel
thank
was
you.
very good. And
Yes, thank you.
Dr. Sushma is a friend, because we've gone to many figures together.
Mm-hmm.
That's
Yes.
right.
Dr. Shubha, your panel was very good.
Thank you
Your
so
slides
much,
were very
Taru. Thank you,
Panel
Taru.
was
मेरा
very.
नाम शोभा है, शोभा, शोभा.
okay.
Shobha
Okay.
ma'am, your panel was
Hmm.
very interesting and
Thank you,
very
Sushma.
crisp.
Hmm. Yeah.
Everything
Yeah,
in
we
our
don't
session.
allow people to sleep. जगह रहना चाहिए.
हाँ.
चलो
Thank you,
अच्छा
Dr.
है,
Madhuri.
बहुत अच्छा. Thank you very, very much for this.
Dr. Shobha ma'am, Dr. Archana Baser ma'am had got some emergency, so she asked me to tell you that.
Yeah. Thank you so much, Rupali. Thanks a
So
lot. And
we call
I
in
just
Thank you,
wanted to
Dr.
wish her,
Rupali.
yes,
because she also conducted
Yeah.
a wonderful conference to which all of us went,
yes.
Samanvay, and I think we all met there. But then, we look forward to her candidature and we look forward to the election. Thank you.
Yeah.
Thank
Please
you very
convey our
much.
regards and wishes.
Yes.
Yes,
Yeah.
thank you.
Thank you.
Okay.
Thank you.
So we
Bye
take
bye.
leave now.
To
Good
Dr.
night.
Shobha and everybody. Yeah. Bye bye bye.
Bye, ma'am.
Bye, ma'am. Thank you very much and best wishes to Archana, ma'am.
Thank you. I will convey all these wishes. We will definitely convey it to ma'am. Thank you, each and every faculty. Dr. Bhagyashri, would you like to give a vote of thanks? A quick, small one, because
Yes,
it's
yes, yes.
late and everyone is now
I would
tired.
like to start by thanking Archana Basir ma'am, who brainchild this focus series. Also, IMS President Sudha Sharma ma'am and Jyoti Jaiswal ma'am. Also, thanking the guest of honor, Jignesha sir. I would like to thank conveners, Rupali Dharwadkar ma'am, Manjum Sayed ma'am, and the panel moderators for a wonderful panel, Madhuri Joshi ma'am, Shubha Godi ma'am. The speaker for today's session, Taru Chaya ma'am, as well as the chairperson, Sushma Verma ma'am, Pragya Mishra ma'am, and Seema Vijayvargiya ma'am, and all the panelists for a wonderful panel. And also, I would like to thank the academic partner, Farmed, for this session. Thank you, everyone.
Thank you so much.
Thank you. Thank you. Let's
Thank
meet
you.
once again for another topic, which is, I think part 2 of menopause should be done. बहुत बहुत miss हो गया.
Yes, ma'am. Thank you, ma'am.
Bye-bye.
Bye.
And
Hi,
I
thank you everyone for joining in. Thank you, Shobha. Thank you, all the panelists, moderator, and chairperson. It was wonderful learning just one topic focus, menopause.
thank you
And
so much.
thank you.
And I request all my seniors to promote more and more uh, uh, gynecs to give CIMP exam because it is a great learning experience.
Yes, I saw your convocation was amazing at Bhopal.
Yes, ma'am.
Yes,
So I request every senior to promote juniors, colleagues, and other gynecs for giving the exam.
definitely.
Thank you, ma'am. Thank you so much.
Thank you,
Thank
ma'am.
you. Good night, everybody.
Good night, everyone.
For a wonderful seamless platform, Sudeep ji format. Special thanks to you.